Those at the back, please come down and let's fill the seats in front, okay? So that it gives a better shot. Those at the back, please come down and let's fill the seats in front, okay? So that it gives a better shot. Those at the back, please come down and let's fill the seats in front, okay? So that it gives a better shot. Those at the back, please come down and let's fill the seats in front, okay? So that it gives a better shot. Our colleagues downstairs in the exhibition room, please come to the main hall. Please come to the main hall. Those at the back, please come down and let's fill the seats in front, okay? So that it gives a better shot. Our colleagues downstairs in the exhibition room, come into the main hall. To the main hall. Please come to the main hall. Those at the back, please come down and let's fill the seats in front, okay? So that it gives a better shot. Our colleagues downstairs in the exhibition room, come into the main hall. To the main hall. Please come to the main hall. Those at the back, please come down and let's fill the seats in front, okay? So that it gives a better shot.
Hello?
Our colleagues downstairs in the exhibition room, come into the main hall. To the main hall. Please come to the main hall. Ladies and gentlemen, those at the back, please come down and let's fill the seats in front, okay? So that it gives a better shot.
Hello?
Our colleagues downstairs in the exhibition room, come into the main hall. To the main hall. Please come to the main hall. Ladies and gentlemen, those at the back, please come down and let's fill the seats in front, okay? So that it gives a better shot.
Hello?
Our colleagues downstairs in the exhibition room, come into the main hall. To the main hall.
Hello? The symposium is about beginning. Those of you outside, please enter and let's start. If you're done with your snack, just come in. Let's begin the symposium. Thank you. Shall we invite Mr. George Toniga to introduce to us the moderator of this session? Let's give him a round of applause as he comes to do that.
Thank you. I deem this a great privilege and an honor to be here to introduce the moderator for this second session. The person I'm about to introduce is an astute researcher and a professor. Following university ranking news, he is number 2 in UHAS and number 3 in Ghana. And this is what I have to say about him. He is the immediate past Pro-Vice Chancellor of the University of Health and Allied Sciences. Before his appointment as Pro-Vice Chancellor, he was the Director of Kintampo Health Research Center, the Ghana Health Service under the Ministry of Health, and a senior lecturer in the Faculty of Infectious Tropical Diseases in the London School of Hygiene and Tropical Medicine. He is an epidemiologist. He had his basic degree education at the University of Ghana, Legon, a Master of Science degree in Applied Medical Parasitology at the Liverpool School of Tropical Medicine, and PhD in epidemiology at the Swiss Tropical Public Health Institute, Basel, in Switzerland. He started his research career at the Noguchi Memorial Institute for Medical Research, University of Ghana, some 30 years ago. He later moved to Navrongo to work as a pioneer staff on the Ghana vitamin A supplementation trials, which later became the Navrongo Health Research Center. He undertook several research studies in field and clinical epidemiology in Navrongo and served several years as a management member. He was later appointed as the director of Kintampo Health Research Center under the Research and Development Division of the Ghana Health Service, where he served in this for 14 years. He spearheaded research, diversifying the scope, expanding on research collaborations with various research institutions, attracting funders to Kintampo Health Research Center, and building both human and infrastructural capacity required for excellent research. He has been principal investigator for several large and clinical intervention studies trials in Ghana. Of special mention is studies carried out on the most advanced malaria vaccine that is very close to licensure as the first ever malaria vaccine to be deployed. His main area of research is infectious disease epidemiology, especially malaria. He has extensive experience in the design and implementation of large and longitudinal studies and is well known in maternal, neonatal, and child health intervention studies, as well as in communicable diseases research. He has served as member of several WHO committees as temporary advisor. He was a board chair of the In-Depth Network for 4 years. He has served on several local and international committees and boards. He has over 200 publications in peer-reviewed journals, several technical reports, conference presentations, and has co-authored 4 books. Ladies and gentlemen, with a round of applause, shall we welcome Professor Seth Owusu Ajay.
Thank you very much, George. I wasn't expecting this long essay on me. I think we are late in terms of the activity plan for today. So I will go to just introducing this session captured as, I should keep changing. As soon as I'm losing voice, then I change. That's wonderful. The role of our institutes and schools at UHAS during the COVID-19 pandemic. So I'm not going to talk about the roles. You've seen the directors and these line up here. My plan is to introduce this session and then give each of them about 6 to 8 minutes to tell us what they did to sustain us during the COVID-19 pandemic. But when I was asked to do this, I had a little challenge with the organizing committee, of which I'm one. It's talking about during the pandemic and making it look like we are now out. So I brought this slide, which I picked up from the Ghana Health Service site this morning. I don't know how current it is, but it came up this morning. Really, if we use during, it will look like we've now moved completely out of it. But I want to draw our attention to the fact that there are active cases as we sit here, which are grossly underestimated. Beyond that also, we have new cases that are coming up. So look at the blue color there, and then it's orange. I can see orange. But it's yellow actually on the laptop here. So the 32 and the 606. And to caution us that we are not completely out of the woods yet. So whatever we've been doing to guard ourselves, we should continue to do that. In fact, I had a face mask, and then when I went out, I bought one of the sanitizers just to remind me that I'm still in the COVID protective mode. Now, it's only one slide I'm showing. On the right side, to your right, I talked about vaccination. And if you remember, the keynote speaker mentioned about the fact that about 30%. I should change now. It's coming. Change. Come. This is a daunting task. Press that press. It's on. Hello? So, about less than 30% of our population are fully vaccinated. There is vaccine hesitancy, not that we don't have the vaccine. Among health workers is a huge problem. In fact, the nurses, the community health officers who are vaccinating us, some of them even discourage us when we go there for the vaccination. We've been trying to look for money to assess for those of us who have taken the vaccines, whether we are still being protected or not. And for the different vaccines, that has not been possible. There's no money to do that. So I don't, you've taken the vaccine, but I cannot tell for sure whether you are protected or you are not. Then my worry heightens when people who are vaccinated go down with the disease. Then they say because I'm vaccinated, the severity of this is not too much. I don't want to get the disease. So I'm always protecting. I have my mask here. The other thing is, even if you are not vaccinated and you are living among several people who are vaccinated, they give you some, what we call herd immunity, some protection. So we want to look at the effectiveness issues surrounding this vaccine, and it's still unanswered. For the diagnosis, in fact, I had a nice chat with one of the tables that they mounted there. They said they have rapid diagnosis testing. And I was asking, so if I've had the doses of vaccine and they test using the antigen antibody test, what they find, is it the vaccine that is protecting me or is a new infection? We're battling it out there. I wasn't totally convinced about the answer, but all I want to say is that we still have challenges. Now, when we were hit hard by this pandemic, there was lockdown at some point. But we were worried about ensuring that we end the academic year. So better late than never. So at some point, we were given the chance to bring back students to school. For us as workers to come to the offices doing our normal work. What was done to enable us continue with whatever we were doing and to complete the academic year? I think those students have graduated or they are yet to graduate. To enable them complete and have a new batch is what our deans and directors will be talking to us about. So for some of you, it will be a learning curve. For others, they will not totally convince you, so you may want to ask a few questions. In the beginning, I said I will give 6 to 8 minutes to each of them. We'll still have enough time. Then I'll come back to you, the audience, to seek clarity, to ask questions or whatever, managing this within the time allocated to us. And if we have time, we'll get some take-home messages from our deans and directors, and I will close this session for the day. This is how it's planned. So on that note, I will go according to the list without any, sometimes I say ladies first, but I think it's a lady that. So I will ask Prof. Evelyn Ansah to tell us what IHR did. Please listen carefully, take some notes. You may have questions, but you won't ask when she is done. They will go one after the other to the last person. Then I will for us to discuss the issues. So, Prof. Anton, you start. I think you start according to the list, isn't it?
No.
It's not.
Can we do that?
But by the powers invested in me as the chairman, we are going to go through that way. Just introduce and talk. Thank you very much.
Thank you very much, Prof. Owe. So my name is Evelyn Ansam. I'm the director of the Center for Malaria Research in the Institute of Health Research. During we are still in the pandemic. So in this COVID-19 pandemic, there are a number of things that we as an institute contributed or did. One of these was to conduct studies directly. And as an institute, some of our team members conducted studies on COVID-19 vaccine hesitancy among adult population in Ghana. And this was done in the Volta region, way before it was realized that the region was going to be the region with the greatest hesitancy in the country. So that study was conducted and it's been very well cited, that study. Another study that we conducted and is also published is on COVID-19 vaccine uptake among the health workers themselves. We thought that if the population is not willing to take the vaccine, what about the health workers? What are they doing themselves that may be influencing this? And we had a study that was published in that. So and other studies we did. These are just two of them. Beyond that, we also supported other schools and institutes to conduct their research. And the ways in which we supported was, you heard the director present on the funding opportunities alert. We advertise opportunities for funding on COVID-19. We also facilitated the seed grants and faculty grants that related to this and other studies. We also provided research management from our research operations office to support all the studies that were going in that direction that were done here in the university or in collaboration with others. The third thing we did was to provide supervision to some students from the schools around who were conducting studies in the area of COVID-19. And we as an institute used our expertise to do this. In addition, we also facilitated the ethical review of a lot of these studies that were conducted on COVID-19. The other thing we did was to contribute to the National COVID-19 Technical Coordination Committee. So members of our institute contributed to this, and our own Prof. Oye, who is the chair, was asked to chair the Research Coordination Thematic Group, whose mandate was to either conduct research directly or to coordinate all research in the area of COVID-19. And this is meant to advise the national committee on which direction to go. So in this area, all these areas, about 5 areas that I've spoken about, we as an institute contributed to facilitating things around during the pandemic, and we are still doing so. Thank you very much.
Thank you. My name is Professor Richard Asma, Dean of the School of Basic and Biomedical Sciences. So I would share with you the role the school played during, even now, after the critical phases of the pandemic. Now, when the pandemic arose with all the panic global, the university management called a stakeholder meeting and assigned roles. One of the roles that fell to us was the diagnostic part. So what we did was to mobilize in that as the school hosts the university laboratory infrastructure and also equipment for diagnosis. So we did mobilization of the resources that we had, and with support from the university management began the initial testing. We started with one real Pcr machine, and along the way, but this has also meant that we had to mobilize all the biomedical scientists within the university into one group, and that came with, so we had biomedical scientists from the School of Allied Health Sciences working with us, and then several university personnel also being part of the team. So with this unified synergy, we had a good team that looked at every aspect of what we needed to do as a university. So we set up the first testing laboratory and began the testing. Testing. We still
the world over. And we do this by basically helping to preserve and authenticate the accumulation of knowledge creations of past generations and ensuring that these are not lost to subsequent generations. The library collects information, preserves information, organizes and disseminates some of these materials to support teaching, learning, and research. In fact, in the tertiary institution, the library supports scholarly communication by facilitating research, teaching, and learning. During the pandemic, libraries, and especially the library in UHAS, realized the need to position ourselves so we can provide information to all our constituents. There was the need to provide information to our health workers. There was the need to provide information to our researchers and then to our students. And so the library did just that. We ensured that we provided relevant information to our faculty and then to our university community. And basically, the library used technology to do this. Whilst we had the lockdown and everyone was at home, the library endeavored to use existing technologies and then also emerging technologies to reach out to all our constituents. Indeed, it was during the time of the COVID that the library wrote and received a grant from the Medical Library Association, Librarians Without Borders. We received a fund to organize workshop on the theme, increasing access and use of research for life resources by health and agriculture professionals and students in the Volta region of Ghana. And this was done between 2020 and 2021. So the program was actually started in 2020 online, and then we finished up in 2021. The aim of this program was to bring together academics, researchers, clinicians, policymakers, all in the health and agri-science disciplines to collaborate and share information and knowledge on resources for the responsible conduct of research. It was also during this period that the library provided information or helped with reference managing. And so the library conducted a number of training programs, one of which was the reference management training with Mendeley. I think I'll pause here, and then when the questions come, we'll discuss further. Thank you very much.
I was nagging her a bit. I mean, your time. Thank you, you heard me. But I don't nag you. Next time, don't see.
Thank you very much, Prof. Good afternoon. My name is Professor Ernestina Donko, the Acting Dean of the School of Nursing and Midwifery. I want to share with you what the school has been doing since the COVID-19 started in 2019. During that time, school was in session, and there was a meeting between officials of UHAS and officials from the whole teaching hospital, which included the Vice Chancellor was there, the CEO of the hospital was there, some deans from the various schools were there, and some of the personnel in the hospital. and Sonam also was part of that meeting. So, and Prof. Binka also was there. And they briefed us on the COVID. That time we hadn't started recording cases in Hope. So they briefed us on what we should do, what we should expect, and to strategize and to plan so that we'll be able to manage the cases in case we start receiving them. So from that meeting, we were divided into groups, and was that group that was instructed to design messages, health messages for the community that we are in. So the information that we also received, we also share it, faculty, the staff, and our students. And around that time, some of our students also were on the field. And before I come to that, you know, from that meeting, then we decided that we have to buy Veronica buckets, soap, tissues, sanitizers, all the things that, you know, we needed to help us, you know, to ensure that, you know, we don't contaminate ourselves with the condition. So we did that, and then we placed the Veronica bucket at vantage points at the school in Trafalgar. And then we kept on encouraging our students and then our faculty to abide by the COVID, you know, the instructions that have been given. And as I was saying, that time we had our level 200 students on the field. So we, that's where they are in the first place. They have inadequate information on the condition, and there weren't enough PPEs. So, you know, once the students are here, we have to take good care of them and then ensure that we protect them. So we have withdrawn them from the facilities, and then they came. And when they came to, we started having we continue having our lectures, and then observing social distancing, putting on face masks and all of that. But later on, the students were sent home. And that time, all our lectures have been face-to-face. So we joined the university to be trained by ICT so that we can deliver our lectures online with the students. So that's what we did. So since that time, anytime we want to do online teaching, you know, it started from there. So this is something that the COVID has, you know, taught us to be doing. And then apart from that, examinations, we realized that we have practical components and then we have the theory. The practical components, we couldn't examine our students at the clinical site. So we had to engage them at the skills lab and also to do the practicals. They had to write it. So written practical examinations, that's what we did. And then in terms of their project that they have to do, the project was converted to long essays. That one, they wouldn't have to go to the field to collect data from their subjects. So we continued with the long essay for some time. So now, where we have resorted to go back to them writing their projects. And then we also encourage our students, we kept on developing messages for them, for everybody to be vaccinated and all of. So we played a major role in educating our community, the community around us, to be able to adhere to the instructions that we have all been given. So this is what has continued up till now. And some of our students too, who got the condition also, the university took good care of them. And we also participated in everything because, the students, as I said earlier on, once they are here, we are their parents and we have to take good care of them. So we did that. So the process still continues. Thank you very much.
Yeah, my name is Professor Erikofori, the Dean for the School of Allied Health Sciences, and also acting Dean for School for Sports and Exercise Medicine. I'll report mainly on SARS because when the pandemic started, the School of Sports and Exercise Medicine was about to commence. As we are, most of us are aware, SARS has a number of departments, and our main mandate is to train allied health professionals. One of the departments is the medical laboratory sciences. We train student medical laboratory scientists. Now, during the COVID pandemic, as the Dean for the School for Basic and Biomedical Sciences had already treated SBBS together with SARS, personnel from SARS, specifically faculty from the biomedical sciences, team up to work assiduously at the COVID center, the sample collection, sample analysis, and all those ones. SARS faculty, especially for the medical laboratory sciences, work effectively with them. And they've been working with them since in the real diagnosis of the COVID and aftermath. Apart from that, the school also did, in fact, during the inception of the pandemic, we did a lot of advocacy role to create awareness about the pandemic and its effective preventative strategies. So most of the things that my colleague deans have said, we're all involved to make sure that people, our students, our faculties, and even our environment were highly educated in the area of the COVID prevention. So that is one area we feature strongly. Research also, you'll see some few research during the COVID with faculties from our school partnering other schools, also faculty from other schools to do research also. Online teaching came in, and like my dean, my sister has said, we have to also avail ourselves and try to deploy all the online strategies and tools to make sure that the academic calendar runs smoothly, to make sure that students graduate and the COVID do not have so much impact on the studies. So we put forward everything that we can to make sure that the school runs effectively. I must say that as a school, we are fortunate. We have a whole cohort of allied health professionals from laboratory sciences, radiography, physiotherapy, nutrition, dietetics. So we have all these group of expertise there who are ready to collaborate with other schools in collaborative research and multidisciplinary research in the area of COVID. So this, in brief, what our school did, and we are still doing it. You go to the center, you see that the lab people are strongly working there. Thank you.
Thank you. My name is Frank Edwin. I'm the Dean of the School of Medicine. COVID changed quite a few things with the way we teach, the way we work. Some of them still present now, and I'll talk about mainly three things. First, the expansion of e-learning. Then I'll talk about how we manage the health system delivery. Then the last thing will be research. So in terms of e-learning, the school, the programs were severely disrupted, as you can imagine. Not only could we not teach students face-to-face, but going to the wards to teach them became problematic. So it was realized very quickly that unless we did something about it, our programs were going to be disrupted beyond. So the school acquired, I wasn't the dean then, it was Professor Tagwa who led all this. The school acquired a Zoom account through which we organized lectures, discussions, tutorials. And even up till now, it has extended beyond the point where we now have a collaboration with the Brown University in the US so that their faculty are able to teach our students using the same e-learning platform. That has been a benefit. Without that, we wouldn't have had these people teaching. As the other deans have mentioned, we also had to use the UHAS learning management system. We uploaded our lectures, put up videos there for our students to be able to learn. One tool that we discovered during this whole process was the Lecturial System. The Lecturial System is an online platform of lectures recorded in video format where students can go to. It gives you kind of a 5 to 10 minute summary of various topics in medicine. So the students could quickly go there and get a brief summary of most of the things. Very useful for revision. It also has question banks for lectures to use, students to test themselves and assess what they are doing. So that was something that we found that was very, it's a subscription service. The university helped us with the first year, second year to do that, but now students subscribe to that themselves. And it's something that we have found very, very useful. As you can imagine, when COVID came, it was a new disease. Much of what the pathophysiology was, how the disease comes about, how does it affect the human body, a lot of it was in evolution. Most of us didn't understand it then. And so as doctors, we needed to teach our students what this whole disease is about. But much of the research was not being done here at the time. So we got one of our alumni from the University of Ghana, who is an infectious disease specialist. He gave us a Zoom lecture, and that became the foundation for understanding the basic pathophysiology of the disease. In terms of the health service delivery, our school was involved in forming the COVID-19 response team. So our dean at the time, Professor Tagwa, Professor Kuku, were part of the team that the university put together to form an emergency response team. As you probably would be aware, the UHAS and the whole teaching hospital formed this emergency preparedness and response plan, which our school again was involved. We were responsible for the clinical aspect of that program. And our faculty were involved in developing the protocols for cases that were suspected and cases that were actually infected. They had to design spaces within the hospital, find a place to isolate patients before they were transferred. So that was a very big role that our school had to play. In terms of research, as at yesterday when I checked, I think I found about 9 or 10 publications that had resulted from multidisciplinary research from faculty in the school. But probably the one that I want to talk about to conclude is one that was done by one of our students as a dissertation. So he studied the impact of COVID-19 on the health-seeking behaviors of patients at the whole teaching hospital. The general understanding was that because of the COVID and the lockdown, the effect on all the hospital units would be the same. Every place is locked down, no patients are coming. But what his study showed was that the pandemic didn't affect all the departments equally. In fact, the units that were affected most severely in terms of outpatients were ENT and eye. Dental unit as well. And then when you came to the ward, in terms of admissions, a lot of admissions went down. But when you looked at the isolation ward, the admission to the isolation ward went up over 1,000%, which was quite incredible. One of the things that I expected to find was that there was going to be an increase in the number of people who had been brought in dead to the hospital. if you looked at the news at the time, this was very common in many countries. In fact, there were some countries where people were just dropping dead on the streets. You couldn't get caskets to bury them. But this student established that, at least in the whole municipality, the increase in the number of people brought in dead was only 5%. So it didn't affect that number that severely. However, those who died on admission went up substantially, over 1,100%. So that was quite something interesting that he found. I think I'm here and pass it on.
Thank you very much. The School of Pharmacy went through all the things that my colleague deans have mentioned in the area of teaching and learning to facilitate the training of the students up till now. We are continuing to do that. But in addition to that, the school decided to get into an area so as to reduce the risk of the university staff and students getting the infection. And so looking at what was happening around us, there were so many people producing sanitizers. Some of them were spurious preparations, some of them were good quality preparations. And to make sure that staff of the right product on the production of sanitizers. We did two types of products, the gel type and the spray type. And we did quite a number of various volumes. And these we sold to the university community. Interestingly, there were many people who came outside to purchase some of these. The university was magnanimous to give us some, about 20,000 for something we carried on for a long time. We have displayed some of the sanitizers out there. If you went to the exhibition, you will see some of them. Just before the pandemic, some of our colleagues, a group, have won a grant to look at antimicrobial resistance in the whole teaching hospital, and had given some training on infection prevention. And that came in time, that was timely, because that really helped people to live their lives so as to getting infected with any kind of infection. So it was very timely. In addition to that, we, some of our colleagues also got involved with looked at some new areas. During the pandemic, people used kinds of products to protect themselves or treat themselves when they had infection. They thought they had infection. And one particular area is the use of herbs. And presentation during this seminar. Who really has gone and has done a lot of things during this pandemic. Do that, particularly to prevent the disease when you get it, treat and live better lives. I believe that sorry, my name is T.C. Fletcher, the the School of Pharmacy.
Thank you very much, and good afternoon. My name is Paul Amuna. I'm the acting dean of the Fred Binka School of Public Health. Our school is the only school which is off the whole, university community area. Our school is based in Hohoi. Therefore, we sometimes appear to be a little bit far removed from activities here in Ho, but that is not exactly true. However, in relation to the pandemic and the part that we have played in the school, there are a number of things that I want to highlight. First of all, in January 2020, it was our students who first came to us with an interest in volunteering to educate the public because they had heard about this disease that has started in China. In fact, some people were skeptical, but the students were right. And they felt strongly that we needed to educate the public about this unknown disease and to help prevent it. So that's, I think, the credit has to go to the students. And by March, when the declaration has been made, and I think the keynote speaker this morning, the historical journey of COVID, we work very closely with the regional hospital in Hohoi, as well as the municipal directorate. And therefore, we were part of the emergency response technical team that actually sat down to strategize in terms of how we in Hohoi would implement the directives from the Ministry of Health and the Ghana Health Service along the lines that WHO had started. For example, in case definition and contact tracing and things like that. And so we're part of the team, and we continue to work very closely with the health directorate and the municipal hospital. The thing that we did early on was that we were approached by the media, and they wanted us to give information about this new disease that even we did not fully understand. And I remember, Chair, that in my office with you, we actually had a media visit, and then we planned. And so we started a series of radio communications once we had some better understanding and feel for the disease. And we started some public engagements, community education, and even answering questions from the public on the radio. One of the key we were concerned about when the first case in the Volta region was actually announced in the hospital, that there was a sense that victimization was going to be a big problem. And so we had to go on radio and try to public on these issues and to talk about victimization. The other thing that we did in line with the university's own directives was to implement the public health measures that we still continue to do to this day, given the fact that even though predictions for COVID for Africa in terms of health did not materialize, we still know that the pandemic is very active. We partnered with the Hohoi Municipal Hospital, and we bought some of the sanitizers from the School of Pharmacy and donated to the hospital. The hospital did not have PPEs, even gloves, and they came to us and we donated gloves to them. And when we got face masks with the hospital, we also gave them some of the temperature guns that they needed for screening patients and people coming through the hospital. We helped them to set up a system where there was a security system entering the premises, and I'm sure we had a similar contribution at the whole hospital. And then we further worked with the the municipal directorate and contributed to the refurbishment of a facility that used to be used by WHO's ONCO group. And that became the holding center and isolation unit for the hospital. And we called it the infectious disease center. That center has been in operation. The deputy minister for health came to inaugurate the center, and we're very proud of the university's contribution to that. And then our students, again, they volunteered to be part of the contact tracing team for the directorate. As you may well know, the School of Public Health, among others, trains students in disease control, epidemiology, and health information, and so on. And all these students volunteered, and they went rotational basis on rounds to do contact tracing and to help with managing the condition. Then, in terms of research, a number of publications have come out, the scientific literature, based on work that was done by my colleagues in the school. They have published work from the social, cultural, and other aspects of COVID, and these are in the scientific literature. We also started publishing work for the general public in the daily media, so that we will help to educate people and help understanding in this area. Lastly, I want to add that in addition to being involved in some of the national dialogue and strategies, we were also involved in regional and global meetings, seminars, conferences, where various members of my team as experts gave presentations and supported the discussions. So going forward, one of the things that I think we need to do, and from this morning's session and listening to the keynote speaker, is the issue about vaccine hesitancy, the low rates of vaccination, and the need for public health education. And so our health promotion unit will be leading in this area to see what we can do within the Hohoe municipality to promote this. Thank you very much. Great. You hold it not too close to me. Frank, yes, thank you very much. Well, you've heard our deans and directors telling us some of the things that they did to cross from pandemic during the pandemic. What's happening? I don't think we will happily want to go back to another peak. So it's my prayer. We've crossed over. And you say, amen. Now, I hope you can hear me. When I try
So if you find me shouting, it's not that I just like shouting. I'm trying to do it so that you can hear me. Notice that most use it, but because we to the audience, if a pertinent issue we will try and close the section as quickly as we can. Is there anybody who would like to ask a question, maybe seek some clarification or make a contribution? Yes. Who will help me? There are some hands up. Okay. Just behind you. Yes.
The chair and the audience. My name is Dedola Depo, a professor of sports and exercise medicine. I just want to back up my dean that the School of Sports and Exercise Medicine is also willing to be active. Exercise has been prescribed in many ways to assist in activity that we manage COVID-19. There are literatures to that, and the school is already been given an opportunity to have a laboratory that we can have exercises that can be used to manage and to improve immunity. The immune system can be touched through exercise, and I believe that the university community and the entire community will be able to make use of exercises, even homemade exercises, in management and prevention of COVID-19. Thank you very much.
Thanks for your contribution. Yes.
Thank you very much, Mr. Chair. My name is Ache Suman, the School of Medicine. And probably I'm seeking some clarification from my dean, Professor Edwin. I'd like to know what happened during the peak of the pandemic, what happened to clinical teaching and clinical care. I wasn't here at that time, and that's why I just want some clarification. I'm aware that we do not have the numbers compared to maybe the other medical schools, but there were situations where we had to limit of students going to a consulting room or going to the ward. There have been situations we had to reduce the number of beds and some of the wards. Even though our numbers are not that much, we are growing, and we are hoping to get higher numbers in our schools. So how do we plan and prepare for such situations? What happened, and what are the lessons that we going forward? Thank you.
Thank you. So during the pandemic, the peak of the pandemic, as you can imagine, first of all, the number of patients, the numbers were lower than expected. So there were not that many anyway for students to learn from. What we did, a lot of the lecturers in terms of clinical teaching, was to limit the number of students to the clinical rotations or the clinical teaching more. So you would bring in fewer students, do the social distancing. It was quite cumbersome, but that is how we managed it. And then we supplemented that with students going to the wards, examining them, and then presenting them electronically for this. The best is not like the face-to-face lecturer is standing there examining patients with the students and teaching, the time is the best way we could manage. Going, it is clear need is more capacity. If we had more beds, the hospital was, it would be. So what we've done to see additional facilities where additional facilities where additional facilities where students can have exposure to clinical teaching. So some of the surrounding hospitals and clinics, we are engaging them so that we can send students there. We are almost completing an MOU with the Greater Accra Regional Hospital where we can send students as well. So going forward, these are some of the measures that we are taking. But at the peak of the pandemic, as you can imagine, it was not optimal. But what we had to do was just to cope so that teaching didn't come to a halt completely. This thing is not great.
I should do what? So, yeah. Okay. I'm learning how to use the mic. Okay. Those online, please, if you want to contribute, raise your hand. I think my IT people will prompt me, allow you come question. Loud, just unmute, and then there any other. Okay, I see one hand. I have to manage my time now. One here. Next, no hand. Here, no hand. So 1-0. You say what? Those online. Okay. So please, Dr. Moore.
Thank you very much, Prof. Oye, and it's good to see you again. Prof. Oye supervised ED research. Thanks, Prof.
Oh, you can clap confidently. Don't, yes. He's my PhD student. That's what he's telling you. I contributed, isn't it? Please carry on.
Thank you. Sort of a general question. Any of the panel members can answer. What's our view on the COVID-19 caused by the Ministry of Health or the Ghana Health Service? Is over-relaxed? If yes, how can we communicate this to the Ghana Health Service? Thank you very much.
I thought you would tell us your perception. It looks like you have an answer, but you want it from my deans and directors. Who would like to take that? Prof. Amuna, they are pointing to you.
Right, that's a very important question. First of all, I think it was made very clear to us this morning during the keynote address that the pandemic is not over. Even though the predictions in terms of its impact, direct impact on health and mortality in Africa has not been realized. And we are still trying to understand fully why that is the case. Nonetheless, I have a feeling that some of the complacency that appears to be seeping into our national fabric is because people keep asking, they say, it is people in America and elsewhere who are dying from it, but not Africans. And I think it's a very dangerous view. Now, one of the things, I don't think that the health service is paying lip service to the need to be vigilant and to continue to do some of the work. My worry is that we are not testing enough. And therefore, as the chair said earlier, the numbers that we are seeing on a daily basis are far lower than the actual numbers. Secondly, recently there has been a new wave of COVID here in Ghana, but I'm not sure that it has been highlighted to the extent that it should. I would suggest that we should do more testing, and secondly, that we should work hard on public education, particularly to increase the rate of vaccination. Even though we know that, you see, the vaccines that have been produced are not the traditional vaccines that we were used to, where, for example, you give vaccination for polio and the person then is protected for life. Most of the mRNA vaccines that we have now are there mainly to protect, to reduce the hospitalizations and to reduce mortality, but not to stop you from getting the disease and or passing it on. Therefore, I think the vigilance has to continue, but I think we should also emphasize public education, health education, and the Ministry of Information should come back to the studio and do more of the work that they started with. We as institutions also have a very important role to play, and certainly we in public health will continue to provide that public education. Thank you.
Thank you. Well, Dr. Mo, I think he's made a good justice to it. Instead of the Minister for Information coming to educate us and give us this thing, I would differ a bit. I would say you should invite the experts, the area, to give us the right and most appropriate information. There is somebody, there's a hand. I don't know whose hand it is. Oh, Margaret Ofori.
Yes, Prof.
You are allowed to contribute.
Thank you, Prof. And thank you.
I don't see your face.
My network is weak, so
you can speak.
Yes, please. Thank you for the opportunity and kudos to IHR. This is a well-organized program by all standards. During the COVID.
Are you sure? Margaret's hand is there.
Yes. During COVID, a lot of innovation.
Are you muted?
No, I'm not muted.
Oh, okay. Somebody read the questions and let us know. But unfortunately, I'm looking at the time.
I'm not muted. Prof, can I go
ahead? Or you are
happy
to forgo your lunch break? No, you should, because.
Prof, can I go ahead?
Okay. I'm not sure if it's Margaret's hand.
Yes,
or whether she can hear me.
Yes, I can hear you, Prof.
If she comes in or anybody comes in, we will allow them.
Wow.
I will give a minute, 1 precious minute, to each of our deans and directors to say something that maybe from the interactions, it may be the questions asked, it may be something they forgot. Just say that in a minute. And Prof. MG, you are timing them. When the person is going over, let me know.
Thank you very much, Prof. Owe. I would like to say that the pandemic is not over. There are others that are coming up, as we can see. And therefore, the lessons we learned and the contributions we made are still valid. But for us as a university, we may need to think about ways of working with our community around us to overcome the massive vaccine hesitancy that we are seeing in this region in particular. Thank you very much.
Next.
Thank you, Chair, Moderator. Now, I would want to mention to an aspect of work done during the pandemic, which bordered on post-mortem analysis.
We may need to think about ways of working with our community around and overcome the massive value.
Yeah. All right. Okay. So together with the team from the 37 military hospital, we looked at 3 cases on people who died supposedly from COVID. That is, and it gave us insights into what has happened to those who died during the pandemic. And obviously, all the 3 persons had secondary issues in terms of other diseases. And it highlighted that the pandemic also, in a way, because of the panic, made many people who, under normal circumstances, will not die. So those are, it's important for us to really have a holistic approach in terms of future pandemics that we have. Thank you.
I learned those online. We have a couple, so please let them also, otherwise we'll be in trouble. Okay, so who is speaking now?
Margaret, please.
Margaret, you speak.
Okay, I'd like to say that this is a well-organized program by all standards and are equal to IHR and UHAS. I noticed that during the COVID pandemic, UHAS did a lot of things and we had our vaccinations and all that. But one critical observation among everybody, including health workers and the community, especially within Volta region, is the mystery surrounding the vaccine and its side effects. My question is, what are we as researchers doing towards curbing such superstitions? Because whether we like it or not, there are side effects accompanying the vaccines. And depending on the person's constitution, you may either experience severe—
Margaret, your question again.
How are we as researchers—
Margaret, that's the question.
Okay, how are we going to
Is she also
overcome
lost?
No, I am online, Prof.
You're in trouble.
How are we overcoming—
Margaret.
Hello, Prof.
That's the question. Say it again.
How do we convince our people, or how do we overcome the side effects, the fears surrounding the side effects of the COVID vaccines? How do you overcome the fear of the side effects of the vaccines, the COVID vaccine? That is why we have a lot of people hesitating to vaccinate. Hello?
Okay, Margaret.
Prof.
I'm so sorry that our system is not working. We can't answer your question.
Okay.
But your dean will be coming to the school very soon. So direct the question to her.
All right,
if she
thank
can
you.
answer, it should be cascaded to the chair. Who is the second person there? Let's try and see if that works. Do we have a second person? No. Okay. So please, those online, even if you have a question, just send it in the chat. We will look at it. Quickly, you have 30 seconds now.
Thank you very much. I think that one of the things that we realized during
So now online teaching and learning has become part of our approach to engaging students. So I just want to add that any situation that we find ourselves in trying to find solutions to them, we have to be innovative and be creative. Also, now many people have come to terms with the use of washing of hands. So let us all use washing of hands. Let it be part of us so that we'll be able to take good care of ourselves. Thank you.
Mine is just advice to especially our students and even our faculty. You know, our training in this university is such that we require knowledge and skills are acquired through this intra-semester and inter-semester practicum. So every now and then we send students across the whole hospitals in Ghana, some go to Accra, wherever. But knowing very well that COVID is still around, we have to take good care of ourselves. We have to continue to practice the preventative measures as we go out. Other than that, we will continue to interact with people. And by so doing, when you come back, the potential of bringing COVID back again in the school is that. So let's continue to exercise all the protective measures, even as we interact with our various clients and hospitals across the world during our intra and inter-semester practicums. Thank you.
Thank you. Yes.
Thank you. So mine is more of a question. It's clear we still have work to do with this COVID. Last month, I was at a meeting in Morocco, 300 participants, about half from Africa, half from Europe and America. We were there for 5 days. We finished the meeting, we get home, and we find that most of the people from Europe and America had COVID. They tested positive soon after they got home.
Protective
Almost
measures,
none of them.
even as we interact with our various clients and hospitals across the world during our intra and inter-semester practicum.
The researchers.
Thank you.
You are not, yes, asking me to
thank you.
answer
So
this question.
mine is more of a question.
We are
It's clear we
Africans.
still have work to do
And
with
we
this
are
COVID.
Europeans.
Last month, I was at a meeting.
Black skin. We should be proud of that.
So I would like to re-echo the fact that we are not out of the woods yet. And therefore, we should continue to observe the protocols as much as possible. And as a school, we will up our game with the sanitizers and go on to detergents and disinfectants to help prevent the disease from spreading. Thank you very much.
Thank you. I wanted our new registrar of your promise, but take note. He said they will continue and ask what? Detect. If they don't do it, we will hold them responsible.
Thank you. Whilst we are on the subject of continuing to take care of this problem, I'm also interested in two things that were said this morning. One was about
Thank you very much.
community engagement, and the second one is about preparedness for the future. And I want to propose that with the IHR and others, we will look at setting up a research which looks at some of the reasons why we have some of the difficulties in terms of getting the message out to the community and ways in which we can better understand the sociocultural and other dimensions influencing people's response as part of our preparedness for the future. Because as was said this morning, a pandemic or a major emergency is not far away from us, as has already been demonstrated by the monkeypox and Marburg. Thank you.
Thank you very much. I think there is a burning question and you read it out, isn't it? Yes, Hubert will do that quickly.
Okay, so this question is from Bright Diapem. He says, it was obvious the role played by the university in case confirmation. Can we know the role of the university in case management? Thank you.
The role of the university in case management. Oh, I thought that was addressed by the deans. It was addressed. Maybe the person missed that. But maybe, Frank, you can just summarize that. The roles.
Okay. He says, it was obvious the role played by the university in case confirmation. Can we know the role of the university,
but you are not
the role
talking.
of the university in case management? Thank you.
The role of the university in. Okay, you carry on. It's not working. You see, they are telling us to close. So I'm going to close now.
Thank you. So basically, it's through the whole teaching hospital. If there's a suspected case, there are testing facilities that is run by the SBBS. If the person needs to be seen by a clinician, that is available at the whole teaching hospital. We have people, 3 people from the School of Medicine on a helpline. And if anyone needs help, they just its management will be instituted. Thank you.
Yeah, I just want to add that in Hohoi, we were relying on the university's testing center for results. So we had a waiting time between when samples were taken and when the results came back. In the meantime, we made sure that when there was a suspected case, if they were displaying symptoms, then they were detained. Otherwise, we asked them to isolate, beg your pardon, quarantine until such time that the results were out. So that was how we also supported management. Thank you.
Okay, thank you very much. I think we bring in this section to what I'm excited about. Fact that COVID pandemic, we learned certain things that has become part and parcel of us. I think online learning or teaching is one area that has been talked about by most of the deans. If to be locked down, not necessarily for purposes of COVID, we know our plan B. Beyond that, even with the disruptions in the academic calendar, the innovation should come in, whereby we don't adopt only the face-to-face teaching, but we can engage our students in very crafty ways that will help us cover what needs to be covered. I also heard the dean of pharmacy. He's looking up instead of looking at me. And he's promising us that there will be sanitizer production in our institution. It's not for free, you buy. But they are going to add detergents because this will help us fight not only COVID infections, but other infections. The health education drive, the collaborations with the regional health directorate are openings that came as a result of the pandemic, and that I'm hoping that we'll make this a status quo so that more interactions will take place with them. I think these are some of the points that I picked that I wanted to re-echo. The ICT is here. Our learning management system should be live, and we should use it, especially for our students, the sandwich students, because there's no space anywhere. I think they are supposed to come in September, and they are overlapping with the regular students, and it's not going to be possible. They can do some of these courses through the LMNs. I wish, on behalf of the organizers to thank deans and directors making this session so, and I'm hoping that they will be available to take some of the suggestions that have come out of this meeting forward to help in the growth of UHAS. And for our collaborators who came in from outside the UHAS community, I think let's forge together, let's work together. If there were any good practices that you picked, please adopt it. We will be there to support you. You can make me a consultant. I'll be available for that. Thank you all very much for your cooperation up to this time. I'm sure there will be some announcements from now, so I hand over to the MC. Thank you, thank you.
Thank you. Yeah, you can. And so the arrangements for lunch, let me acknowledge our sponsors, Fred's Kitchen, KCS, Ghana Medical Journal. We're grateful for your support. And let me also acknowledge the presence of our Temple Health Research Center. We acknowledge you. We have Dr. Dennis Edu Jemfi, Dr. John Amwa, Dr. Kali Senram, and Mata Abdullah from Kintampo. Dodua Health Research Center, Dr. Solomon Nabana, and Veronica Afetokbo. Thank you for being part of this. The arrangements for lunch are this. The opening at the top are closed now. We are not using them. We are all descending, and two main entrance as exits. So you present your cheat at the entrance, now exit and pick your lunch pack. That is not the end of the program, so we are breaking, Prof. MG, 1 hour, right? Okay, 1 hour. We're breaking for 1 hour for lunch. You take your pack, and the basement will be open for around. The first time we went there were so many, you may not have had the fair view and opportunity to look at some of the works being exhibited. So you could pick, you can go down there and still watch. And after 1 hour, we will come for the oral presentations. It's very important. We will come at this 1 hour for the oral presentations, and we'll call it a day. Thank you. So those are the announcements for this session. And so those who are giving us food, are you ready? And are you ready for us? We can start coming out. Okay. Okay. Can start row by row and take our pack. And we are using the other side. We can start coming out. Okay. Okay. Can start. So media. Where's Fred? You join me for lunch, okay?
Yeah, hello. 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 Testing. Testing. Try 2. Testing. Mic try 1, 2. Microphone check 2. 1, 2. Testing. Testing. Try 1, 2. Try 1, 2. Hello 1, 2. Testing. Try mic 1, 2. Oh, yeah, problem.
Please. Hello. Control room, control room. Please on spotlight. Hello. Hello. Testing mic 1, 2. Unmute and talk. You unmute on the Zoom and talk.
Hello, hello, hello,
Hello.
hello.
Yes.
Testing mic 1, 2. Sound check 1, 2. Testing.
On
1,
Zoom.
2, 1, 2. Microphone check 1, 2. Akasamun Soshe Baku Ebien 1, 2.
This is what you said previously.
Testing mic 1, 2. Testing 1, 2. Try mic 1, 2. Try 1, 2. Hello, microphone check 2. Try mic 1, 2. Microphone check. Okay. The brought for back and now stop me how.
Hello. Hello. 1, 2.
Testing mic 1, 2. Testing 1, 2. Try mic 1, 2. Try 1, 2. Hello, microphone check 2. Try mic 1, 2. Microphone check. Okay. The brought for back and now stop me how.
Hello. Hello. 1, 2.
Testing mic. 1, 2. Testing. 1, 2. Try mic. 1, 2. Try. 1, 2. Hello, microphone check 2. Try mic 1, 2. Microphone check. Okay. The brought for back and all stop now. How?
Hello, hello. 1, 2.
Testing mic. 1, 2. Testing. 1, 2. Try mic 1, 2.
Hello, hello. Testing mic. 1, 2.
Hello? Hello, hello.
Hello. Testing mic. 1, 2. Sound check. Try 4.
Hello, 1, 2. Hello, 1, 2. Try mic 1, 2.
Hello.
Hello. Hello, hello. Sound check 1, 2. Try
Hello.
1, 2.
Hello, hello. 1, 2. Chris. Hello, hello.
It's breaking.
Hello. Hello. 1, 2. Hello, hello. 1, 2. Hello, hello. 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 Hello, hello. Sorry.
Hello. My.
The first samples of COVID-19 arrived at the UHAS lab on Monday morning. That was few minutes after the Volta Regional Minister, Dr. Archibald Yao-Lecha, and MP for Ho Central Constituency, finished touring the new laboratory. The sample is received at the spot and disinfected, and then taken upstairs to the laboratory.
As a university that is focused on health and the allied professions, there's the need for us to be relevant in our society. The cadre of professionals in the university whose expertise needs to be brought to bear when it comes to tackling the problems of society. So when the call came that we needed to set up a testing center for COVID-19 in the university, it was the right opportunity for professionals who were in the field of molecular biology, virology, and the biomedical sciences to actually come together to be able to provide these services. We needed to have something to be able to start with. And what we had was the basic things that you need for regular PCR.
We see just assuming that there will be many of them coming. So this is the area we take. From here, we move them to the next time where we do the sorting. So we open the food boxes, we have the sample form and all that we source it to make sure that every sample is coming with the information required.
So this is one of the class 2 biosafety cabinets that we received from Seeding Labs. And these were the two were those that we used to start the testing. So they were the pioneers of the testing lab when it came to containment of the organism. So when we got the sample, we brought them in here, and this is where we did the RNA extractions. So we'll be able to contain the pathogen from spreading to the environment, and also protecting the technicians who are doing, or the people who are doing the extractions. Later on, as we worked, we received this donation from the Ghana Atomic Agency as well. So they gave us this modern class 2 cabinet as well. At the peak of the pandemic, we were receiving thousands of samples a day, and we were using manual extractions to extract the nucleic acids from the samples. Fortunately, the National Testing Network or the National Laboratory Network for COVID-19 testing received these donations or procured this donation. So there's an automatic extractor that you just load with your buffer and stuff, and then it will do the extractions for you and then put them in a plate. So this actually eases our work. It makes our work easier because you don't have to do the manual extractions and go through hundreds of extractions at a time. So this is one of the equipments that we were able to get as a result of establishing the testing center. This is one of the equipment we received from the Ghana Atomic Energy Commission. This is a Pcr that we use for all our clean work. And so we received it from the Ghana Atomic Energy Commission. And it was helpful because it separates all the dirty work when it has to do handling raw samples. But here we only do the master mixes and then use for our PCRs. These also came in through the National Laboratory Testing Network. So these are PCR machines. Each one of these can take 48 samples at a time. And so we received these as well from the testing lab, testing network. And it helps us a lot, especially when the 384 capacity PCR machine broke down. And we were back to using the MIC, which could also take only 48 samples at a time. So this also came in very handy, and it's added to the capacity that we have in the lab when it comes to real-time PCR. So we received 2 of these. So at a go, you can have 96 samples, including your controls, that you can run at a go.
The first samples of COVID-19 arrived at the UHAS lab on Monday morning. That was few minutes after the Volta Regional Minister, Dr. Archibald Yao-Lecha, and MP for Ho Central Constituency,
Good afternoon. This afternoon, I want to share with you some insights about the UHAS COVID-19 Center. And as we've seen from the video, there are a couple of things that have happened, and we are happy to share how in the midst of the pandemic, we were able to mobilize resources. There was a big community mobilization to leapfrog the diagnostic and research capabilities in response to this pandemic. My presentation is going to take this format. I'm going to basically talk to us about the journey, the resource mobilization, the signs and impacts, just highlights of some of the things we've done, and then a few acknowledgements to the people who have contributed to this. So how did we get started with the UHAS COVID-19 Center, which have come to stay and a lot of us actually get to know about today? On Friday, 28 February, around 2 o'clock, I had a call from the Vice Chancellor, who then said that we've had reports of cases in Nigeria, and it may get here. And so he's putting together a team to discuss what our response will be should the pandemic hit Ghana as well. And so he asked if I was available, and if I was, I should meet them at the School of Medicine conference room. So I stopped everything, and then I joined the team over there. It was a joint team between the whole teaching hospital, the ambulance service, and other key stakeholders who were going to play a role. And this particular day for us is very important because that is actually where everything began. After the meeting, we agreed that we needed to do something, and we thought that we would do diagnosis. We didn't know what to do. And so at the time, Dr. Gameli Deku, who was then my PhD student in the lab, I
quote, forced him and said, you know what, we need to do this together. And so I pulled him along, and then we went to Noguchi to look at what they were actually doing when it comes to COVID testing. So we could learn from them and be able to do our own. So we did that the following Tuesday. And then on the 9th of March, there was a community briefing. And so together with Dr. Mlibuachi Yadom, who is also from the School of Medicine in UHAS, we put our heads together as to what the laboratory response will be. And then we briefed various stakeholders as part of the UHAS strategy for tackling the COVID-19 in the Volta region. Having discussed the strategies, the next thing was the resources, because it was a matter of a response we were giving, but there wasn't any resources. And so we needed to do some mobilization. And so for the initial resource mobilization, we had to fall on project resources, basically consumables from various research projects that we had ongoing in our laboratories and in our departments. We also had to fall on some equipment donations that we had received from Seeding Labs, as we saw earlier on from the video. And then also we had some donations also from Novartis as part of some collaboration we had with them and the capacity building activities. And then personal resources. And I do recall instances where my colleague, Dr. Gamil Deku, will go and buy some basic things like bin bags and others that we needed that there wasn't any with his own money to carry to the lab so we can be better prepared to do this. And these were some of the sacrifices that were actually made. From there, the VC requested that we put a team together. And so I proposed a team of laboratory scientists across UHAS. We opened up, looked at everybody who had some background in the biosciences. So from Allied Health, MedLab, SBBS, and all over. And this team was assembled by the VC and commissioned for us to see what we can do in terms of diagnosis. So from there, we did some in-house training. So Dr. Deku and myself had been to Noguchi to see what was happening. We had put a team together and we thought that it would be good that we are on the same level. And so we put ourselves together and we organized an in-house training for ourselves. We did set up the SOPs and went through our quality management processes. And on Monday, 27th April 2020, testing started. And as we saw in the news article by City News, we started in the UHAS COVID-19 Center. So that is how we kicked off. But the issue of resource mobilization wasn't over because we didn't have anything. And at this time, I want to acknowledge some of these people. The Hoteliers Association in the Volta region came together, led by the regional minister, and they were the first people to make some donations to us. They donated PPEs, laboratory consumables, they donated fridges and freezers and other things to be able to help us get going. Alongside, the Vice Chancellor was quite instrumental, mobilized the various contractors around and told them, look, we are starting this, we need your help. And at the time that we kicked off, from the videos, you could see that the regional minister and others were sweating because the air conditions in the lab weren't working. And so the VC mobilized some resources and some contracted, the Fiat Construction, TDK Atlantic, donated some air conditioners, which we still use in the labs today for our activities. GCB came in again with some PPEs. We had the Volta River Authority donating a genset to us and some other donors as well. So here are some of the pictures from our very first donation receiving when the Hoteliers Association gave us fridges for storage of samples, the PPEs and others. And then also we had the air conditioners I've talked about, as well as the donation of PPEs by the Ghana Commercial Bank. Along the line, the COVID-19 Trust Fund received some donations as well from various entities and also did those distributions, which for us, they gave us a single cabin Nissan hardbody pickup, which we took delivery of at the COVID-19 Trust Fund in Accra. And then there was also another key activity where the International Atomic Energy Agency mobilized resources and wanted to support countries. And so for Ghana, they wanted to make a donation through the Ghana Atomic Energy Commission, and the GAEC decided to give the donation to the Ministry of Health to support COVID. And at the time, because UHAS had started and we needed resources, the ministry thought that if they give us those equipment, it will help us. And so that was another key milestone where we had some equipment to be able to boost our initial capabilities. So we went up together, the regional minister was with us to take delivery of those. And later, the GAEC team came around to see how the equipment had been installed and doing with them. Then we had issues with power, whereby power fluctuations here and there was affecting some of the work that we were doing. And so again, I need to mention that the BC was very instrumental, was able to lobby the VRA, and they donated a 250 kilowatt or kilovolt standby generator to the lab. And this was installed as a backup. And so whenever the power goes off, whether the main university comes on or not, the laboratory standby generator comes on and filling for the gap so we can keep working. In addition to all these resources that we mobilized was also the team, and the team was very important. And as I indicated, initially we thought that a lot of people, but these are the people who responded to the call and were part of the initial core team that we started working together. A lot of samples were coming in. We had to divide ourselves into shifts, and we were working at a point 24 hours. So people will come in the morning, some will come in the afternoon, some will come in the night and stay over till the morning. And I need to say a very big thank you to these people whose efforts, without which we wouldn't have been where we are today. As the pressure went down and teaching and others resumed, a number of them had to move on to their core responsibilities. And so this became the core team, in addition to national service personnel who come in from time to time to support the work that we do in the center. So this is basically some of the key things that we want to share with you in terms of how we've come with the COVID-19 center. It's not only mobilizing these resources that we did, but we have also been doing some science and have been making some impact, and we'll share just a few of them to you. So we know about coronaviruses. The keynote speaker has taken us through the history and all that, but I just want to, the SARS-CoV-2 for which we established the center, it's the 7th coronavirus known to infect humans. And we group them into two. We have those that cause severe diseases, where we have the SARS coronavirus 1. We have the Middle East Respiratory Syndrome coronavirus, and then the SARS-CoV-2, which causes COVID-19. And we also have some others which cause mild infections. And so coronaviruses are not new. They've been with us. We've had previous outbreaks, and this new outbreak happened to take a different course, and that is why we see that level of impact. Coronaviruses in general are zoonotic viral particles, and they usually are thought to originate from bats. Bats are thought to be the reservoirs. However, although they are in bats, they are tend to likely pass through pangolins. And so for those who have been in the genomic sequencing era, we have the pangolin lineages, which reflect the key role that these pangolins actually play in terms of the transmission. The history and the origins of SARS-CoV-2 has been a subject of a lot of controversy, but some of the current data, and this is one of the new papers that have come in the last couple of weeks, which actually points to the fact that the Huanan seafood wholesale market in Wuhan was actually the early epicenter of the pandemic. And I brought this up just to emphasize that even though the pandemic started in 2019, as scientists and researchers, you don't just leave things there. You need to get to the bottom of it. And so throughout the period, scientists have actually gone onto the ground, looked at samples that were collected, taking retrospective data, and eventually have been able to at least give us some early have happened from the onset. And this is particularly important because if we want to make efforts to prevent future pandemics, we need to know how the current one occurred in order to put ourselves right. So at the COVID Center in UHAS, what we do as part of the effort to understand the disease and also in response to the disease, we do routine testing and surveillance. We do genomic epidemiological studies, which we use to support the public health intervention, as well as do other research that supports case management and other activities. For testing, we do routine testing for people who are suspected of the disease in the Volta region, in the OT region, and parts of the Eastern region, particularly the Esojamai district. And occasionally, we have also conducted testing for Ada in the Greater Accra region. We have also, so far, in the center, we've tested a little over 26 or well over 26,000 samples so far, of which we've had over 5,000 positive cases out of those. Another key area that we've contributed, which has been one of the areas that we've made significant impact, is genomic epidemiology. And so at a point in time, there was a need for us to understand variants and possible evolution that could occur locally, because if viruses evolve locally, they have a potential of changing the dynamics and the course of the disease. If you get local evolution, you can get a variant that can cause severe diseases. And in the course of COVID-19, we've seen this happening. And so we've heard of various variants, Indian variants, South African variants, UK variants, and all of that. This is because of what happened. And so it was important that in Ghana, we also do that. Initially, sequencing was being conducted in the University of Ghana, and UHAS was the second institution to actually do genomic sequencing. So the initial sequencing was done by Wagbip and Noguchi, and then KCCR sent some samples to Germany to be sequenced. But in terms of local capacity, UHAS was the second to build that capacity. And we had to fall on existing research projects. And we are very grateful to the funders for the understanding that we were in a crisis and there was a need to shift some of the resources that they have given us to undertake various projects into responding to the pandemic, because it was critical. If they didn't allow that, all projects came to a standstill, and we needed to do that, and we are really grateful. So there were efforts we had a sickle cell project funded by Novartis, an antimicrobial resistant project funded by the Gates Foundation, and another sickle cell project funded by the Royal Society for Tropical Medicine and Hygiene. And these were the projects that actually provided the resources, forming the foundation for our genomic sequencing capabilities. In doing this genomic sequencing, we actually contributed data to a number of publications. And at this instance, I want to just highlight some of the high impact papers. So we contributed to a Pan-African wide genomics surveillance activity where we published the very first Pan-African paper detailed the genomic evolution of SARS-CoV-2 in Africa in Science. And then following on that, we also came together as the various labs that were sequencing in Ghana between UHAS, University of Ghana, and other sites, came together to also analyze the genetic diversity of SARS-CoV-2 infections in Ghana from the data that we had generated. And again, we have also gone on to do a second Pan-African collaboration involving SARS-CoV-2 epidemic in Africa, basically focusing on how we expanded on the genomic sequencing and the new insights. And this is also a paper which is upcoming in Science as well, and the preprint. So what are some of the pieces of data or the things that we could take from some of the data that we had generated from our genomic sequencing? We noticed that the pandemic in Ghana had been dominated by the B11318, the alpha and the beta variants, and then at a point, the Omicron variant also came in. And key among these was that importation was a major driver of the pandemic in Ghana. And so when you look at where the different variants were coming from, you could realize that some were coming from Europe, from the UK and other areas, and we didn't seem to have a significant local evolution that actually affected or determined our local pandemic. Our pandemic was driven basically by importation of variants, and as new variants occurred and were imported, it actually drove the cause of our local infections. Again, from the data that we generated, putting it into context on what happened in Ghana, we also realized that the Ghanaian waves followed the global and African waves. But one key thing was that the Ghanaian waves followed a little later than what was happening globally. And that also emphasized the fact that we were getting the importations. And so it happens elsewhere, it's imported, and then our cases begin to follow. And so that seemed to be the trend. And what this tells us is that whatever is happening elsewhere, we shouldn't be oblivious of that, because what is happening elsewhere, it may have an effect on us. And that has been the trend. So whenever there are epidemics and happening, and even in case of COVID, as other countries experience spikes in cases, we need to be prepared, and we need to also keep maintaining the protocols in order to avoid getting out of hand when it comes locally. I've mentioned the genomic epidemiology, and I want to mention that one key person who has been at the forefront working so hard is Rosina, who is actually currently volunteering in the lab. She is a former student. She was the valedictorian of the year. She graduated in our MD program and has been the key person who has been leading our genomic sequencing. She works on all the sequencing with support from the seniors, and that has been a great capacity that she has built. I think we can clap for her. So what have we seen in the Southeastern Corridor, where we are, Volta, Uti, Esojama? We started the first wave, we had very limited resources, and so we did few genomic sequencing. And we realized that in the first wave, basically we're having variants, the one that started in Wuhan, and a few other variants that has occurred from there. The second wave, we managed to generate further resources, and we sequenced a lot more. And that is when we began to see variants such as the alpha variants, the beta, and the eta. But key in the second wave was the alpha variant, which actually dominated our pandemic and also reflected what happened in Ghana in general and in other areas as well. And then again, from the data that we generated, we also realized that the third wave actually having a lot more variant this time round. And the third wave was mostly the Delta variant or the Indian variants which came in, and various subvariants of the Delta. And we were not spared of that. It had a significant impact in our environment as well. And then the fourth wave. And the fourth wave is where we have seen a change. Whereas the Omicron has been the dominating one when you look at the country as a whole and other areas as well, here in the Southeastern Corridor, we rather had a B, which looks like we were going backwards, because the B happens to be one of the very early variants that we saw. And initially, when we saw this data, we thought there was something wrong. We had to repeat the sample times and get some other colleagues elsewhere also to check it. And we realized that no, this is what is happening. We are still looking into this because this could actually define a new course of the pandemic. We don't have so many cases, even though the cases are coming up, but noticing that we have a variant which doesn't follow the general trend requires. This is one of the key things that we are beginning to build upon to provide more insight into what is happening, particularly in the Southeastern Corridor, Volta, Uti, and Esojamai in the Eastern region. In summary, for our genomic sequencing, we've seen that a wide variety of variants have occurred throughout the period in the Volta OT enclave, and which mirrors the other parts of Ghana, except the wave 4, as I've mentioned. And there is a need to continuously monitor. One other key thing is that with the exception of the first wave, the subsequent wave have been dominated by just 1 or 2 variants, although there are others in the background. So we see a transitioning dominance in there, which is also very key. And it provides some advantage in terms of putting in intervention, because if you don't have so many variants, you can tackle the 1 or 2 that you have. But if you have a wide variety, that makes it difficult. So that may be a positive sign, but the fact that each wave is a new variant makes it more worrying, and why we need to continue monitoring this particular aspect. Other activities that we've been doing together with the Ministry of Health, we are undertaking differential diagnosis. This is a collaboration between us and KCCR. And basically, one of the key things that we realized was that there were a lot of cases that came into the lab suspected of COVID, but a lot of them were not COVID. So we asked, what would be the case? And we thought that before COVID, there were respiratory infections. So could it be any of these other respiratory infections? And for this, the Ministry of Health, through the research coordination group, which is chaired by our former Pro-VC Professor J, has given us some funding, and we are doing some differential diagnosis, looking out for other viral and bacterial respiratory pathogens that could cause it. And also, we also have a project in place where we are developing isothermal detection devices. We want to be able to empower the labs in the various health facilities tests and do molecular testing. And so we are developing isothermal test kits, which can be used at that stage. And you don't need expensive equipment to use those ones. And we're also collaborating with WACBIP and other agencies to do seroepidemiology to look at the level of exposure. One last key thing that we've done in terms of impact that I'll highlight is that we have become a training hub. And so we have collaborated with the WHO, the Ghana Health Service, to organize some training for various people. And now we host most of the training for the laboratories in the Volta OT enclave as well. So what are the next steps, our outlook? Basically, what as a center or as a lab we look at is to be a hub for the study and surveillance of emerging infectious disease of public health concern. And so we've set out with a mission to offer this cutting-edge training and research services in diagnosis and control of priority diseases for public health in Africa. So this is what we try to do. And specifically, we have established and we are providing cutting-edge reference and supported diagnostic services, and we hope to build this capacity. We are created an enabling environment for high-quality training of bioscientists. We are collaborating with the Department of Biomedical Sciences in SDBS. We are providing training for the graduate students as well. And we also have other students coming from elsewhere to train. And we're also collaborating with local, national, and regional hubs to undertake surveillance of priority diseases. And I've highlighted some of our contribution in the Pan-African effort as well. And finally, to provide genomic sequencing services for research and public health. This is a capacity that we build locally, and we want to expand on that. There are so many people who have contributed, and I'll just want to highlight these few people. These have been the core people that have been behind. Dr. Ivo Jani, Dr. Jones Jemfi, Dr. Grace Pelly have been very key in all the activities that we have done. Sometimes I'm the face. These are people who have been in the background providing all the support, and we are really grateful. We also want to acknowledge all our funding partners. These people funded various projects, but allowed us to use some of the funds to do COVID, whereas others, like the Ministry of Health, the National Lab Network, have continuously provided consumables for our work. And finally, I want to say a big thank you to our Vice Chancellor, whose efforts, without which we wouldn't have been here. He has been the key person who initiated it. He has led in most of the mobilization that we've done, and we are eternally grateful for him for the support that he's given us. Thank you.
Thank you very much.
a few questions before the next speaker comes. So if there are any questions, you can raise your hand.
Thank you very much. For excellent work done, for putting the blame on the university on the map, and for the continuous high level work that you are doing. Now, we feel that this is
Thank you.
A very small question. When you talk about the risks and the failures where the students, you know, the most way the US and Europe have been leading involved in the failures. I didn't seem to see that how serious of how risks are based on.
Thank you very much, Paul. So for now, the data we've generated, we've not seen those ones. Count for them. And so we are still working. One of the key challenges that we've had is that the sample transportation, the storage, sometimes by the time the sample gets here, they are not good enough for sequencing. And this has been the major problem. For example, recently we prepared about 1,000 samples for genomic sequencing, and only about 96 of them passed. And one key thing has been the storage. And we've talked to our colleagues, and they are having similar challenges as well. So we are working with the people on the ground, because without good quality samples, we can't get this information. Thank you.
Issues that relates to the infection levels beyond
Should I take another one? Okay, so that is a very important thing, and it's one of the stories or the instances that we remember. So I remember at one instance, DC had to come and talk to some senior colleagues and try to explain to them that they should give us that opportunity to work, because they equally had these concerns and didn't think that we should continue with the work on campus. And one of the good things is that throughout the period, we didn't get staff getting infected. And that for us was a very good sign. It was later when we started getting national service people coming in, and even that we looked into it and it looked like they had had the infection before coming in. And so I think one of the key things that we put in place was the infection and control. And with the stigma that was around, it actually put us on our toes, because we knew that with the kind of apprehension that started, if we are not careful and something goes wrong, that will be the end. And I think with that, we're able to push ourselves to the limits to be able to put in the best infection prevention control measures in place. And so far, your issues so far.
I'm usually concerned when we get donations of equipment, because oftentimes when they break down, we've had instances where we've got donated equipment, where it generates money, breaks down, you bring that technician from Europe, he comes, he collects all the money you raised, start again, nothing breaks down. You go through that cycle over and over again. Do you have any plans, maintenance contracts for the equipment that you have?
Something which is still happening. So for some of the equipment that we have, we've tried getting maintenance contracts, but it's been expensive. Currently, the National Lab Network, we've come together we are speaking to the American Public Health Association, who have indicated that they will support, and then the African CDC. And so what they are discussing now is that they will get a general maintenance contract for all of us, so that whichever companies will go from country to country, lab to lab, to be able to help, because we are not able to actually afford these maintenance contracts. And yes, some of the equipment, we had a 384 well PCR machine, it broke down, but the technician said it was an old machine that was out of, it's sitting down at a white elephant now. But this is a real problem that we need to look at. And so we need to build capacity in those areas as well.
Thank you.
Thank you.
Help me with the next speaker. Determinants of COVID-19 knowledge among Ghanaians.
It's my slide.
It's not for you, right?
Determinant. It starts with determinant.
You give it to them.
Yes. I give it to them.
You have it on a blouse.
Yes, I have it on my blouse. Yes. Yes. The slideshow mode. Yeah, good afternoon. My name is Miss Mavis Pelkwabla, and I'm from the Binka School of Public Health. And I'm presenting on determinants of COVID-19 knowledge among Ghanaians. So this is the outline of the presentation. Sorry, it's not in the slideshow mode. I don't know.
Just moving the slides and look at the one out there.
It's not in the slideshow mode.
It's in the slideshow. Send it. So look at the one up there and ignore the one here.
I can't see them.
Look at the one on the board.
Okay. Yeah, so by way of introduction, the devastating impacts of COVID-19, we all know, has been felt in the global health economies, human lives, when it first started in 2019. Ghana was also not left out. We also had our share, where in June 12, 2020, Ghana recorded the first case. And of course, the cases increased up to a point. Misconceptions and appropriate knowledge about COVID-19 have been reported by some studies in Ghana. And successful management of COVID-19 has been linked to the level of knowledge of the population. And hence, regular assessment of knowledge and risk perception of people is very important. At the time of this study, there were few studies on knowledge, attitude, and practices. But these were studies among a cross-section of the Ghanaian population. At that time, a study that is nationally representative was not available. And so we assessed the factors that are associated with COVID-19 knowledge among a wider section of the population of Ghana. So the study area, it was a nationwide study covering all the 260 districts in Ghana in all the 16 regions. So data collection, we conducted an online survey between August and December 2020, and using a cross-sectional design. Of course, at that time, we tried to limit face-to-face interactions to avoid spread of the disease. And so we adopted online platforms using mobile phones and computers for our data collection. The questionnaire we used actually was adopted from WHO. WHO was giving the questionnaire to just one research team. So we applied early and we got it. So since they gave it to us to use for the whole country, any other person that applied to them to get the questionnaire, they refer the people to contact us. And if we decide that they join us to conduct the study together, then that is it. So we had a number of people contacting us to partner with us for this study. We estimated a sample size of 2,600. And in each district, each of the 260 districts, we trained one district health promotion officer who served as data collectors. We got ethical approval from the Ghana Health Service Ethics Review Committee. And this study, because it's a nationwide study, we collaborated with the Health Promotion Division of the Ghana Health Service. And that is the reason they gave us access to train all the health promotion officers in every district. That is how come we've been able to cover all districts, because of the collaboration with the Health Promotion Division of the Ghana Health Service. So this data for this presentation was part of a larger study looking at behavioral insights for COVID-19. The questionnaire was really covered so many variables. So this is just an aspect of it. Of course, we use both descriptive and inferential statistics, and we conducted multivariable logistic regression to investigate the factors that are associated with COVID-19 knowledge. So in all, there were 2,721 people that completed the interviews. And of course, females much higher. In terms of educational level, because of the online nature, we got over 60% of the population being those that have completed tertiary education. This is the regional distribution of participants. We realized that for a few of the regions, there were quite a number of non-response. And so you can see the Northeast region, for instance, there were only 6 participants, which was far less than what we estimated. So in all, 93% of the participants were aware of the pandemic that was going on. and males were in the majority when it comes to knowledge about the awareness, sorry, of the existence of the pandemic. Common symptoms like fever, cough, and shortness of breath were over 95%. And then we tried to ask participants to rate their knowledge of COVID-19 and compare it by testing them with actual questions. And we saw that 81.7% rated their knowledge as good in COVID-19. But when we came out with basic facts about COVID-19, we saw that only 65.9% actually had actual good knowledge. And then also we saw that there's equal proportion of those with knowledge on effective measures and practice. We try to see whether if you are really acquainted with the effective measures of COVID-19, whether you really practice them. And we saw almost equal proportion. And then also there were some measures that were not effective, but our participants mentioned them as part of the effective measures. Some are not traveling abroad, taking caution when you are opening mails. These were not considered as part of the effective measures, but they were listed as effective measures. And then we try to look at the confidence of individuals, the confidence of the population in individuals and organizations handling the virus. And you can see from the bars that the state TV, this actually was on a Likert scale between 1 to 7. And people have more confidence when they get information from state TV. That is the last, and then also from radio, state radio. So it means that people really have confidence of the kind of information they are getting on COVID if it is coming from these sources. So there were a total of 9 variables that we found that were associated with knowledge of COVID-19. The first one is age, more than 56 years. So aging kind of reduces your odds of having good knowledge by 49%. And then having tertiary education has a higher odds of knowledge compared to those with no tertiary education. And then also we found that residing in the Greater Accra region increases your odds, has a 2.0 odds of increasing knowledge. Probably in the course of the COVID, more education was kind of going on in the Greater Accra, being the center. And then also the opposite is that in the Upper East region, residing there actually reduces your chances of having good knowledge. And then we saw that those who were not infected actually have a higher chance of having, or odds of having good knowledge. The same applies to those who know somebody who is infected with COVID. We saw that those who are misinformed are 30% less odds of having good knowledge, of course, and that is obvious. And then also those who perceive the spread of COVID to be spreading at a very low pace, they tend to have a 30% decrease in knowledge. So we found that adequate knowledge of COVID-19 has the potential to influence the adherence of the populace to instituted, governmented precautionary protocols. Majority of our participants were aware of the existence of COVID-19, with females having a higher proportion of awareness compared to males. The odds of having good knowledge of COVID-19 decreased as the respondents aged 56 years and above compared to those in lower age ranges. So the strength is that the study was a nationwide study. covering all the 260 districts and all the 16 regions. And participants, after taking the interview online, were directed to the Ghana Health Service website, where they can have more information, credible information about COVID-19. The limitation is that it was an online method, and that actually favored those who are educated. And of course, we had small sample size in some of the regions. So we found that the study found good knowledge regarding COVID-19 among the respondents. The Ghana Health Service should continuously provide accurate information to educate the citizens to prevent misinformation, which is vital in stopping the spread of COVID-19. So we had, like I said, WHO was a partner that funded this project, and then our collaboration with the Health Promotion Division of the Ghana Health Service, and then the co-authors. Thank you for listening.
Thank you. Thank you very much, Ms. Any questions for her?
Right, there's a gentleman, his hand is up there. Thank you very much for a very good presentation. Yeah. I think the presentation was actually very good. And I can see that you used within the time that were allocated. That is very good. But I have two questions I want to ask you. The first one has to do with from your data, you realize that the females seem to be more aware of the COVID-19, not have COVID-19 knowledge compared to the males. I don't know whether there's a reason for that or something. Maybe, I don't know, you have published the paper, so I've not read it. Well, if you can throw more light on it, I'll be very happy about that. And then another question, which I think it has escaped me. Thank you.
Okay. So regarding paper, we actually submitted this paper to +1, which is currently under review. That is just the first aspect of the whole project, like I said. Of course, females having good knowledge compared to males. We could say that in the era of the pandemic, of course, somebody said we are still in, but we are not actually in the heat of the pandemic. Women probably want to be careful, and so they really want to know what is happening. And you see that those who really have good knowledge about this, they are able to follow some of these instituted precautionary measures. So that could be the reason that probably women were searching more. And that's the reason they are really much aware of the pandemic compared to males. Of course, there were studies that found the opposite of what we found, but that is the situation in our case.
Hello. Thank you very much for the nice presentation. I want a little clarification. You said the data collection was online, but I also heard you mention that you use health promotion officers to collect the data. So I just want a clarification on that.
Okay. Yeah, so everything is online. Even the health promotion officers, we train them online using via Zoom. So we train them, we send them the questionnaire, and we realized that if we had to send this questionnaire to individuals to answer on their own, there will be a cross-section of the population that we might not get, especially those who are not on smartphones. So what we did was, there were some people they contact, and once those people are not able to take the interview by themselves, they call them on phone and interview them. So there were a few people. If we hadn't done that, like we don't find people in the higher age ranges. So it was basically online, but some of them we had to call people and interview them, and then we enter the responses.
Thanks very much for a good presentation. I was just curious. I'm just becoming curious. You kept stressing that most of the people you interviewed were from tertiary level. I'm still wondering why you did not get people a little even lower, like secondary school, SHS or something, unless your definition of tertiary was included those from the secondary school. And then whether you could not translate, that was the reason why you did not go get other people even who were not educated, sort of.
Okay, thank you. So actually, the target population, we are looking at those age 18 years and above. So these are the people that we you won't find anybody below 18 years in our data set. Of course, when it comes to translation, this was the reason we had to combine sending the questionnaire to people in addition to having to call people and interview them, so that those people maybe that are not educated, that wants to take the interviews, we actually use the language of those people. And so that's why we use help officers in all the districts of Ghana. So some interviews were conducted in other Ghanaian languages, apart from English.
So thank you for the presentation. Just a follow-up. I think obvious that looking at the class of persons that you have, results actually found from the study, I mean, that we should have people with good knowledge of COVID-19, looking at persons you were interviewed. These are people with education. Looks pretty. The other one has to do with the female, having more female well-informed than the males. Don't you think your sample size has a role to play? Looking at the gender for the sample, you have more females compared to the males. So one would be expecting that comparing both sexes, you should be having more female having good knowledge than the males.
Okay, thank you. If you look at the proportions, the females were only about 54, so just about 55%. So that is not much of a difference. But of course, you are right, that could be the reason for the differences. Apart from the female, what?
Thank you very much for a very good presentation. Mine is one of trying to get myself unconfused. You said that 99.3% of the participants were aware of COVID-19. And then you say that there were more females than males who were aware. And you mentioned 54.7%. Just for my understanding, this 54.7%, and is that the proportion of females who were aware, or I'm just a little bit confused about that. If you can just clarify that, please. Thank you.
Thank you, Prof. So the awareness we are talking about here is whether they are aware that there is a COVID-19 pandemic going on. The whole study was about knowledge, and there were different sections of knowledge that we look at. Knowledge about basic facts. That's why I said that even we look at knowledge of basic facts and that's whether it is equal to how people rate their own knowledge. But when it comes to the knowledge of awareness, it's a people are aware of the existence of the pandemic. And we saw that in a whole, 99% were aware. But we look at the distribution between male and female, that part in the study. And we saw that when it comes to male and female distribution, the females kind of proportion.
Please look at the data again. If you have 99% and you say that the proportion of female to male was more, then the females who were aware should be more than 99%. They should be closer to 100%. Now, if you are saying that the first part was whether they had any awareness that there is a pandemic, and then the second part was whether they had knowledge of what was responsible for the pandemic, and there are those differences, then that's, but I think you should go back and look at your numbers again, please.
Thank you, bro.
Just another point. You said that in some of the districts, because of lack of this, they had fewer subjects. I don't know how you did your sampling because the districts are not. If you can just give us a little bit on that, thank you.
Okay, so in terms of sampling, we use proportionate sampling. So we actually estimated how many to take from each district based on their population. So they were not the same. So depending on your population, you have quite a higher number of people than compared to other areas. But the areas that, like the Northeast, that we estimated based on their population, we're supposed to just have 100, and we got only 6 of them. We got that we increase the numbers for and those heavily populated adjust for it. We try to adjust for it by increasing the population for those with higher prevalence, looking at the cases reported at that time. So that's what we did to make up for non-response for those other areas. Thank you.
Thank you very much.
Okay, please, there is a question in the chat box, so I want to read it to the presenter so that you answer for us. From Francis Agboke, he says, great presentation. What could possibly account for residents in the Upper East region being less likely to have good knowledge on COVID-19? Thank you.
Okay, so when I was talking about Accra, I meant that so probably all the educational activities on the media probably was more intense compared to the other places. And if you also see the numbers in terms of the proportion of participants in these regions, you can see that we have a higher proportion of people from Accra because we have to increase the numbers of people. So it could also be the number of people that participated from that region and also the kind of health educational activities that might be going on at that time. So that's what I can say. Thank you.
All right, thank you. I had that same question, but I think he asked it for me. All right, may I now invite Dr. Edu to give her presentation. She's going to speak to us on whilst they pull her talk up, she's talking to us on supporting teaching and learning in adverse times. Academic Libraries' response to COVID-19 in Ghana.
Thank you very much. Good afternoon once again. My name is Teresa Edu, and I'm the university librarian. I'm doing this with a team from the library. Dr. Osman, Hawa Osman, Dr. Dominica J. Dankwa, Patrick Benedicta Boedi, and Fred Haibo. And our theme or topic is support teaching and learning in adverse times. Academic Libraries' response to the COVID-19 pandemic in Ghana. This will be the presentation outline. We'll do a short introduction. We'll look at our objectives, our methodology. We'll discuss the findings, and then we'll make some recommendations. As we all know, in the heat of COVID-19, all educational institutions were closed down. And they now started to find ways of engaging with their constituents online. Libraries play a very key role in teaching, learning, and research. And so the library had to find a way of reaching out to these constituents and the information needs. Some of the libraries extended their loan periods, some suspended fines, some tried to create some kind of awareness or facilitate interlibrary loans and all that, just so that teaching and learning would go on. And so for this research, we try to explore the role of the academic libraries in supporting teaching, learning, and research at the various universities in Ghana during this period. And then also to find out how they served their users. And then finally, we wanted to know what motivated librarians to do what they did during this period. Because of course, a lot of people during this period went home to sleep. And yet there were people who did something. And so we want to find what motivated them to do what they did. We used a qualitative exploratory design using the phenomenological approach. This approach was used because it teases out people's experiences during a particular phenomenon. And this phenomenon we are talking about is the COVID-19. And so we wanted to know people's experiences during this period. Specifically, we targeted library staff who work directly with library patrons before and during the pandemic. And so we designed a semi-structured interview guide, which we used in collecting data. The transcribed interview were thematically analyzed using the in-vivo software. And then we had some themes coming out. The themes were motivation for service provision, resources and the services that were provided, relevance of hybrid services, that is, especially with libraries which had an online presence, the communication channels that were used in reaching out to the constituents, that's the patrons, the services that were in high demand during the period, and then the challenges they went through and the support they received in this period. And so we'll look at each of these themes very briefly. The first is motivation for the service provision. Here, the libraries generally realized they needed to be relevant to their patrons and to the university community. And so they tried to meet the patron information needs by giving access to library services. And then also, it also came out that some were motivated by the fact that they wanted to showcase the library. What does the library have to offer? And so respondent one says that even health personnel needed information. So we realized that we didn't have to let the library close down. We had to find ways of providing them, that is our clients' services. Students were also getting ready to submit their thesis. So we just had to put ourselves together to provide that service for them. Respondent 3 says, we had to go the extra mile to introduce something that can help our users to make use of the available resources. And this is supported by literature. In Pakistan, there was that zeal to reach out to users as well. The second is the resources and the services that were provided. Immediately, these libraries that we looked at established contacts with their patrons, and they used live posters, emails, live chats, and created special teams to respond to their use 24/7. And so there were users online who responded to the queries of users. Respondent 1 says that we sent emails and we also provided live chat services, and we provided posters to help them with some of our processes. 3 says, library, we left our phone numbers on notice boards, WhatsApp, etc., so that when students needed something, they could contact us. This is also corroborated by similar studies that have been done on the use of social media to reach out to library users. The third is the relevance of hybrid services. It was noticed that a lot of the libraries had hybrid services. And by this, we mean they were providing both traditional services and online services. And most of the libraries that were providing this service were able to respond better to the pandemic. In other words, they were able to quickly adjust to the situation on hand and then to reach out to their users. And so respondent 1 says that we provided both traditional and online services. He says this helped us to serve our users remotely during the lockdown. And then the library already has a very robust digital library system. So when the pandemic came, our digital library with its ebook platforms came in very handy. This is also corroborated by studies that have been looked at in our literature review, which says that the online presence of libraries made it very easy for them to reach out to the users. And then also the other thing is the issue of communication channels. How did the libraries reach out to the constituents during this period? In fact, most of the libraries leveraged on the existing but rarely used online platforms. Before the COVID, like I said earlier, the online platforms were there, but these were not used to the maximum level. But during this period, the libraries leveraged on the already existing platforms to communicate with the users. They used posters as well. Some teamed up with the various public affairs directorates to communicate with the patrons. Some use WhatsApp, and some also use their subject librarians. Those who had subject librarians in the various universities attached to departments use these subject librarians to reach out to their users. They said, respondent one said, we provided services through live chats. We had a lot of meaningful responses. People were impressed about the quick responses to their request. This is also corroborated by existing literature, which says that the use of subject librarians as an effective communication tool in reaching out to users. And then the services that were in high demand during this period was reference services, literature searches, and then the selective dissemination of information. And as you can see, the respondents attested to this. Literature also attested to that. Online reference requests increased in most libraries during this period because it was easier for people to reach out to the library through the chat, the live chats and all, and it was also easier for the library to reach out to these people. Definitely the libraries had some challenges in providing the necessary information to the patrons or their users. One was interconnectivity. All the people who were interviewed indicated the fact that they had challenges with internet. Some of them had to use their own data to reach out to their constituents. And then also the unavailability of the necessary tools to work from home. Most of them use their phones and then or their laptops. And so if you do not have a phone, you do not have a laptop that can do what you want to do, then definitely you would have a problem. And then also the issue of the digital divide. It's not all the libraries that were well endowed to their constituents. And so those who were well endowed were able to do a good job. And then those who were not well endowed were not able to do that. L6 says that the challenge was that it was not the normal time that the IT technicians are available that you can easily call. And then there was also a challenge that included network issues. And also we were not getting copies of electronic versions of books that students requested, especially with the law books, with local writers, you hardly get e-copies. So what they were trying to say is that with our local authors, most of their books and the materials they had were not online. And so if people requested for these things, it was hard to provide them. But you can easily get some of these things from other places, especially with ProQuest. This is also corroborated by literature that was looked at. So what are the recommendations and the conclusions for this study? Libraries that had platforms for online services were better placed to respond to the pandemic. And so if a library already had a hybrid system, then definitely they can leverage on that to reach out to the users. And then for a recommendation, we realized that there was a need for in-service training for librarians, especially when they talked about the fact that there were certain things they could not do. And so there was a need to have continuous professional development training for all categories of library staff, especially in IT-related issues. And then also, the pandemic has revealed that investment in ICT infrastructure is a critical approach to responding to possible future pandemics. Nobody knows what's going to happen tomorrow or tomorrow next. But if we are able to have a good IT or ICT infrastructure in any of the libraries that we have, then definitely when there's a problem, we'll be able to reach out to our users. Thank you very much.
Thank you very much. I'll take online questions first, if they are there. Otherwise, if there are any questions in the audience here, I'll take them. Any questions for Dr. Edu? Right, so maybe I can ask you one. I was wondering if students still need to come and sit in the library if internet connectivity works. Elsewhere, I've seen that what students have tended to use the library for now is places of going to sit down and read their books. But in terms of requesting for material, they don't really need to come to the library for that. Is that a correct observation?
I think I'll say it's a yes and no issue. In instances where the library is well equipped and can reach out to the users, yes. But the library is not only for responding to queries. The library also is a place where people can sit and use resources. So like you rightly said, students would come into the library and read their own resources. The library creates an environment where people can use resources for teaching, learning, and then research. Yeah.
Thank you. I see a hand there. There are 3 hands now.
Okay. Thank you very much for this presentation, because it's quite educative and refreshing of knowledge of the use of the library. But this is a research, and my observation and information that I will require from you, I saw 2 things that happened there. One is a semi-structured interview. I would like to know if, maybe not reported here, if you subjected that semi-structured interview to the establishment of the psychometric properties of such interviews. That's my first, maybe observation. Then the second one, what psychometric properties of that semi-structured interview, if they were established. Number 2, the sampling, I would like to know the sampling technique for this interview. Thank you very much.
Okay, so this is a phenomenological study. And with this study, you need between 4 and 5 interviewees to be able to establish whatever you want to establish. And when you go, you get into 12 and above, then you'll be reaching saturation points. And so what we did was to get 3 universities, a public university, and then a medium-sized private university, and then an older private university, because we wanted to cut across. And then we selected 6, that is 2 library staff from each of the universities. And so we had 6 interviewees for this project.
Thanks for the presentation. I want to know what type of service was provided online. What type of service?
I think we indicated that reference services was provided, literature searches were provided, and all that.
Can't we go online and search for those things?
Pardon?
Most of those things can be gotten online, if I'm not mistaken. Oh.
The librarian has been trained with an eye to see things that the ordinary person would not know. And I have a typical example of Professor Edwin here, who sent me a request, yes, just yesterday, and said he had been looking for a material for some time now. He wasn't getting it. But I got it for him this morning. In fact, I got it yesterday, and I delivered it to him this morning. Am I right?
Yes, that's right. Actually, I was just about to ask her, how did you find that paper? I wasn't sure there was a PDF copy, but somehow she managed to conjure it. So yes, she's right.
This confirms the fact that librarians have been trained to look for information.
releases a lot of cytokines, causes a lot of inflammation, leading to the severe and critical stages, which is characterized by acute respiratory distress syndrome. I'm sure we've heard of that word over and over again, as well as multiple organ dysfunction syndrome. So far, routine strategies against the condition hasn't yielded much results. So there was the need to bring on board strategies, which I call novel strategies. We've seen the monoclonal antibodies as RNA-based ones, quite new to us. The use of serum therapy. I mean, people who have recovered and then their serum was used to treat others too, also was heightened, as well as other strategies. The ones that have been dominating now is the use of the monoclonal antibodies. I'm talking about the vaccines, and I'm sure most of us have received our shots. This is it. And then they also use of the antiviral drugs. You can talk of remdesivir, azithromycin, hydroxychloroquine, and then the others. All right. So looking at how the virus finds its way into our respiratory tract system, as well as other systems in our body, and the way it multiplies to produce copies of itself to cause the infection. Four main ways have been studied and known that if we can do something to that, we will get therapeutics against the infection. And then these ways are the inhibition of what you are seeing here is ACE2 receptor. What it means is angiotensin converting enzyme 2 receptor, and then the TMPRSS2, transmembrane serine protease 2. These proteins in the host cell help the virus to gain entry. And then when it gets in, it makes more copies of itself with the use of the PL protein and the 3CL protein. These are their definitions. The PL protein is papain-like proteins, and then the 3CL is 3-chymotrypsin-like protein. These are the main proteins that the virus uses to replicate and make more copies. So these are drug targets. And then it's found out that herbal medications can tackle this. And that's we based on it to say, can tackle these drug targets. And so we can then study more on it to know how better they can do to treat the infection. But one may ask that, why are we looking for herbs as therapeutics against COVID-19? Because of the advantages are many. The vaccines are doing what, inducing immunity. The antiviral drugs, the chemical ones, are reducing severity. Yet we don't have cure. And for some of you who have been in my shoes, took the vaccines, got infected, and then had terrible experience, I'm sure you have come to know that these strategies we have limitations. They are very expensive to come by. Conspiracy theories over, hesitancy rates higher, as we saw today. And then the WHO has made us understand that in our region, about 70 to 80% of the population still relies on herbal medications. So we still expect that the average Ghanaian will think of herbal medication first for treating any condition, no matter how severe it is, before orthodox medications. And I've been in the pharmacy, and we see the indigenous population coming in for herbal medications. They come ask, can't it do something? Can't it protect me against the COVID-19? So there's that need to study, to know more about herbal medications and what they can do in handling this pandemic or infection. Herbal preparations can be formulated as oral formulations. That's the most convenient dosage forms known ever, have good track record, broad spectrum, and can make them in large quantities. So we'll look at some chemistry behind that. That's as evidence for looking at it more. So the presence of some compounds, named here A, B, and C, I won't bother you with the names, but these compounds have shown to interact with the PL protein, one of the proteins that helps the virus to replicate, in extract obtained from this plant called Tribulus terrestris, or locally known as aquafunu or afrum. I'm sure some of us may know what that plant is. And then another study also has showed that a compound called tomentin, and they have derivatives of it. So you can see I have tomentin 1, 2, 3, 4, all the way to 12. Have also
have also shown to have activity against the virus. But these are computational studies. They are molecular docking studies. And so they kind of tell us the interaction, what these compounds then do in the active side of the enzymes to let us know that they can have activity. So with this, all these derivatives you are seeing here, the 1 to 5 have showed beta inhibition, and it's because of this group where the black alloy is showing us. This group, which we can't see exactly here, is responsible for what the interaction it has when studied on the computer. The next class of compounds we talk about is called flavonoids. This is their parent structure. Now, they may have other compounds surrounding it, and that will let us know the specific name. So for camphor, for instance, it means that the position R1 and R2 will have hydrogens, and then it follows. Flavonoids have 3 rings, and in literature, we call them ABC rings as the name. Now, these flavonoids are the most widely studied compound against the most widely studied herbal compounds against the enzymes the virus uses to replicate. And they are shown to have not only antiviral activity, but also reduces the inflammation as well as have antioxidant effect. Surprisingly, we get these flavonoids from our apples, onions, almost all our fruits that we eat. So actually, we have been taking drugs unknowingly, or we have been taking compounds that fight the virus unknowingly every day. And so I'm not surprised that in a region like ours, like where we have good onions, we have good teas and stuff, we have some amount of immunity against the condition. We can also have it as supplements in the pharmacy. So I said they are the most widely studied compound. And then Omofok and his colleagues were able to use molecular docking studies to tell us the interactions that this huge chemistry thing you are seeing here, the interaction that is able to have at the active site of the 3CL protein. I said that the main protein the enzyme uses to replicate in host cells. And they're able to tell us that when you take the A and C ring, when you change the substituents around at this position A, 2, 3, 4, it tends to increase the binding stability of this compound at the active site of the enzyme. But when you do the same at position B, you decreases the binding effectiveness. The same to the study, they dock this compound at the S protein active site, and they also realize that some substitution increases binding, others to decrease binding. And then this knowledge, we saw China. China, though the hotspot of the infection, they were able to gain early control and was even aiming at a zero infection rate. With the WHO thought it wasn't even possible at that time. And as in 2021, China was using all sorts of extracts. They test isolate the compounds, have activity, and see that if it has broad spectrum and can protect the organs, especially protect the severe form of the infection, then they go in for it, make formless preparations, then they start using it. So right now in traditional medicine, there are a lot of plants, as you can see here, and these plants, they've been able to isolate the exact chemical compounds responsible for the activity, from the roots, from the seeds, the leaves, and also ever. So China has really been able to control the condition, and it is one of their main structure was because of their traditional Chinese medicine, which makes use of herbal medication, what we're looking at. In Ghana, what we know so far, a study that has been done, it was a computational study, was done by Bwakoye and his colleagues in KNUST. And they were able to tell us that some alkaloids in Libima, this Cryptolepis sanguinolenta is locally known as Libima, that alkaloids, 13 different alkaloids from the extract of this plant had activity, very interesting activity, could bind and then inhibit the enzymes, showed good statistics that they could really be used as lead compounds to develop therapeutics against the condition.
And surprisingly, we already have a product by Plant and Medicine Research Center for malaria treatment. That is an extract of this plant. So we just have to study more about this product and see how we could use it to control the condition, or how better it would do to treat the COVID-19 infection. This is telling us the free binding energies. The more lower it is, the better the energy, the free binding energy, the more that compound can be used or can offer as a lead compound to develop therapeutic. So these are the interactions. For example, we could see that the compounds could have hydrogen bond interactions, pipe-to-pipe interactions, all sorts of interactions at the active site, telling us that they can really interact at the active site of the enzyme, the main proteins, block replication, and so should be studied in vitro. So what is happening currently with this from this study is that there's a clinical trial ongoing approved by Ghana's FDA. And then the study group is studying in human subjects to know how well it can control. We have not heard much about it because of when the wave went down, but they are getting some good data. Another plant that an extract has been obtained from is Artemisia annua. This extract of this plant is where we obtain artemisinin, what was used to develop the ACT antimalarials. An extract from this plant has shown dose-dependent inhibition against the SARS-CoV-2 and the SARS-CoV-2 virus, the virus. And then the idea that extract from this plant would inhibit the viral growth or the virus came from the claim of the Madagascar president when he said he has come out with a drug called COVID organics and then could treat the condition. But the WHO suppressed that because we don't want resistance against the antimalarials that we have. So this group studied, Neil and his colleagues studied about the drug in 2020, and then a confirmatory study has been done this year to show that it really has an activity. And then we can see from this graph that the extract even does better inhibition than artemisinin itself. So the idea from the study that there could be something more in the extract that was responsible for the activity or gives better activity aside the artemisinin that we thought was responsible for what? For the activities. And we see at 8.3% increasing percentages, we get good inhibition of the virus. Currently, it's also in a clinical trial in Mexico, trying to probe further to know how safety issues with it before it can gain approval. Then another plant again here is called Echenia. It also reduces symptoms. A lot of in vitro studies has confirmed that. It's also in clinical trials. So far, we look at the compounds that have been studied against the SARS-CoV-2. Phenolic compounds in pie chart A, occupying 72%, is the most studied compounds. And under the phenolic compound, we have variety compound derivatives under them. The one most studied is the flavonoid. This gives us insights if you want to look more into it, where we should look to. And then the drug target in the virus, the M proteins or 3CL protein, is what has been learned, that what has been studied much on with herbal drugs. In Asia currently, there have been a lot of formulas, herbal products in the form of tablet injections, pills, treating at the various stages, the pathophysiological stages of the infection, the mild stage, the moderate, severe stages. And so this encourages us and then motivates us that we can also do something about. So I'm concluding my presentation by saying that herbal compounds and extracts could be used to develop effective medicines against the virus. And as I said, if you don't use this knowledge now, it may be useful in the future. And going forward, as clinicians, as healthcare researchers, we collaborate more and then move the study further so that we can get to a point where they can be approved as medication. But that is what the ordinary Ghanaian is looking for. Thank you very much. Thank you very much, Richard. See, I'm a surgeon, so these benzene rings don't sit too well with me. I was wondering whether you had some herb to treat COVID or something. You talked about the Madagascar people, but what about Tanzania? You didn't talk about Tanzania. Anyway, you don't have to answer that. Any questions from the floor?
Thank you, Richard, for your very eloquent presentation. I studied pharmacology in 1983. So when you start talking about angiotensin binding sites and things like that, my knowledge is very, very far away. But I like the whole concept of using herbal preparations to address challenges in our health sector. What I don't like is the fact that more often than not, when your colleagues and yourself talk about these things, you are very silent on the toxicology of the products. I mean, you've told us all the excellent things. So you take a herb and it can cure almost everything. Yeah, but we are not being told its effect on the kidney, its effect on the liver, its effect on the major organs in the body. And I worry when I don't hear such things, because in normal clinical trials using allopathic medicines, you would normally go through phase 1, phase 2 studies. That is studies that are done in animal models before you come into the human population. But your group just jump into the human bodies. Is there any information on toxicology on any of these things that you talked about?
Yes, sir. There've been some results from studying these molecules for the safety. Most of these are pharmacokinetic studies, but they were done in silico with computers. They simulated them. And some too have moved to in vitro studies, and then the results was good. So for the studies that are moving to clinical trials, most of them, if you look at the paper, they are hopeful they will work, with the exception of the safety issues. And that is what they want the clinical trials to address. And so that is why we've not seen much progress moving herbal drugs from the one stage, from the lab or the bench to clinical trials, get them from there to the shelf for them to use. It's a major problem. And so the organizations, the FDAs, they are very keen on that. They know
Published in phase 1, phase 2.
Yes.
But many of us are just ignoring that with these products. And I think we should find a way of addressing it, because it is very important. And you and your colleagues should find a real way of addressing it. Because if you bring a product that hasn't gone through safety in phase 1 and phase 2, it will be very difficult for us to approve it in human beings.
Yes, Prof, I get you very well. And then that is why some of us are also getting on board with those in the academic area, so that we can help the local people who are majorly the ones bringing the herbal products onto the market. Then we sort these issues out. Initially, the people who were bringing the medications did not even know much about this. And we wonder how they were able to get the
on the market. But now, when we get more academicians coming on board like this, we can look at that aspect. They already have that knowledge that the drug can do this. And when we test, we see that they can do that. So we look at it from that aspect and then we move on. We're able to deal with what you are saying. All right.
Okay, thank you very much. I have some general questions, so don't take it too personal. I'm wondering if the molecular docking studies have pointed to some potentially active compound, why not just do synthesis other than trying to go the herbal product way? Because if you know the compound, why not synthesize it and develop it? That's my first question. And then the second one is, most of these natural products have multiple compositions and synergies coming. And so sometimes when you isolate one substrate, it doesn't work. In our current environment, these are mental problems. How do you think, talking about the future prospects, we can navigate those, taking into consideration toxicology and other things that VC has already mentioned? Thank you.
Thank you, Prof. The first question has to do with why are we not isolating the active compounds? Why are we not synthesizing them? Rather than, the very first reason is that motivation is not there, because most times these compounds fail, as you said. When you take them out of the extract, they are with a lot of other compounds there. When you take them out and you work on them, they don't work. So now the chemists have to spend much time, it may take years now doing something to compound to get activity. And that's even been the way many drugs came onto the shelf. So most times they don't work. Secondly, that process is very expensive. The synthesis is very expensive. So most of our people that you've heard, that they've helped in a way to bring new medications on board, they did it outside. For example, our own Prof. Ataja, they did it outside. It's very expensive to do it here. Looking at that cost and then the time range that it will require to do that, we now think of, let's see how we can refine the extracts and see we won't have a lot of safety issues with it, and try. If that works, then we can move it from that step to what you are talking about. That was the same story for artemisinin. The Chinese people were already using it to treat malaria for years. Then they realized that now let's take it a step further. Isolate that compound, do something to it to even get metal derivatives out of it. So when you take that compound, it doesn't work and it's very expensive. The motivation is not there. Even we young ones that have gone through some education, we still feel that going through that way, it's something that you may end up with nothing. So let's pass through the extract way and standardize it and see how it will work. We have a lot of extracts working in Ghana here. For example, if someone wants a drug that can take care of or protect the liver, most often what you get as herbal extracts, they work. We don't see a lot of safety issue because they work on it. So when we can go that direction, that will be better and then cost effective. And that will even bring more people on board. And we also have the medications already, just picking them to do more study on them. That will be better for us now, the country, as a developing country. And when we reach that step, we look at isolating them. Then the second thing is, you said how do we navigate the challenges? The first thing I think we need is collaboration. We may do all the wonderful works in our labs, but if we don't collaborate with the FDA, if the government hand is not in it, if the Ministry of Health hand is not in it, trust me, whatever you do, when you get there, they won't mind you. So it will remain on the shelf. So collaboration is the first. When they accept it at the top level that this is a direction we should start looking at, I'm sure we can begin from there.
Thank you very much. I want to commend you, first of all, for an excellent presentation. I'm very impressed with the depth of your knowledge and understanding around
some of the chemistry. I understand you are a 5th year student in pharmacy. Final year. That is very, very impressive. My only caution is to add to what the VC and Prof. Dwedu have said, that we should stick to the science. And much as these herbal products may have a potential, we should be very careful. You know, we have to not throw caution to the wind. When we are talking about safety and other things, sometimes when receive this feedback, you don't even need to respond to it, except to note and to say, yeah, this is an important thing to be considered. But sometimes there is a feeling of people trying to market products rather than to say, look, these products seem to be having an effect. The in silico and in vitro studies are promising. However, we need to do all these things in order to get them to the stage. And you are right. A lot of these drugs went through these phases and it's tough. But I just want you to exercise a bit of caution when you are presenting these things. But I'm very, very impressed. Thank you very much.
Yeah, thank you very much for your excellent presentation. I want you to make a clarification on when you are dealing with the Chinese traditional medicine. I don't know if I heard it right. We're saying that it looks like the Chinese traditional medicine appears to have contributed to the controls they had been able to have it over.
Exactly.
So I want to know whether it's from literature or because I seem to be following the Chinese environment. I know that they have a strict protocol. For example, in China, if one case is discovered in UHAS campus here, the whole community will be locked down. You see, so there's, I know the protocol was so strict, the extent that, in fact, sometimes the population begin to fight the government, but they are not, because they are communist people, and the way they do their things, once government says A, there's nothing like a demonstrations against what government, they understand that once authority says A, that is what is happening. So I think their control level has to do more with the protocol, the strict protocol they're using rather than, unless you have read that in the literature.
Yes.
To prove that their traditional medicine is also contributing there. I don't know.
Yes, please. Their protocols have helped. But after cases have been confirmed, I mean, the lockdowns limited cases at a point so that it doesn't spread. But the traditional medicine takes it from after cases have been confirmed, and then these patients also already have preference for the traditional Chinese medicine. So they move most of them in there. And then most institutions too were like ours, tertiary institution with a teaching hospital. So for the patient that went in there, they did those studies together. They ran the herbals as well as the orthodox medications, especially some who didn't respond to the orthodox medications, but rather got improvement with the herbals. So that's where these data are coming from. This is not from only literature. At the beginning, I was also following because I got curious about this COVID thing. And I realized that the hospitals were doing more, I mean, they were employing the use of herbals, but I didn't know that there was a whole huge of literature backing what was happening. So that's what diverted my attention there to now go and look into the literature. Is it true? So if I find a product, I look at the plants in there, I search on what is in that plant, that is controlled, and I found that association. So it wasn't only literature. That's what they actually is contributing to the treatment. But what you said, the protocols have more to do with the prevention. I hope you get me. They had more to do with the prevention, but this one went into the treatment, and that's where it was able to make its name. Thank you.
Thank you very much. I also want to congratulate you for your
your grasp over the subject and how you communicate it. But this particular area is one area that I'm very concerned with. I heard you say two things. One is that the Ghanaian population likes taking herbal medications.
Rely.
They
on
still
herbal
rely.
medications.
So it means that they really rely on that. So they take it. And you even said that they sometimes will take it before they go for orthodox medicine.
Please, I said that is the first point of call.
It's the same thing.
Okay.
So let's leave the semantics. Just get what I'm saying. So whether if it's the first point of call, it means they will take it before they go. So it's the same thing that we are saying using different words. But the thing I'm concerned with is what VC has said and what Prof. Amuna has emphasized. And I'm concerned with this in the light of what you said about the fact that you take the active ingredient and it won't work. It doesn't work. But in an extract form with other compounds present, it seems to work, which means that is not the only one that is working, but there's some interaction that goes on to make it work. But whilst I'm happy with that, I'm concerned also about the other damage that may be going on with that group that is going on or that is doing seemingly some good. And that I find seems to be glossed over. In fact, it seems to me that in approving herbal drugs, the sort of rigidity that is applied to orthodox medications by the FDA, it's not the same sort of rigidity that is applied for herbal drugs. And I'm a bit concerned about that all the drugs that are being freely advertised, what is it that is harming the body? And if we want to run fast, we may cause damage to run. So what are your comments on that?
Thank you so much. So it's okay. Okay.
Sorry, I just want to confirm that you are a level 600 student.
Yes, sir.
Okay, because I saw intern, so I thought you had finished your program already.
That is now what we do at the final year. It's no more after.
Okay. So you're one of the Japan babies.
Yes, please.
Oh,
I am one.
I very much applaud you. I didn't realize you were still a student. Otherwise, I wouldn't have been so hard on you. So please don't answer Professor Ansah's
I
question.
won't answer. I was even about to channel it to Prof. TC to help me here.
So such questions should be directed at Professor TC Fletcher and his school. I think you've done an excellent job. I didn't realize you were a level 600 student. I thought you had finished and you were an intern, because recently we recruited some PharmD graduates to help in the training of Professor TC Fletcher came with a very nice excuse why we needed to recruit some PharmD graduates. So you are a level 600 student. Please don't answer anything again. Let's give him a clap.
You've done extremely well. So they say VC should answer the question now.
Okay. The question. Maybe later on.
The question is now redirected
so
at
I think
TC.
that will be done privately.
TC is not going to answer the question.
You had a question, but he has been waiting already.
Okay, all right. One more question from the audience. Two?
Yes.
Okay, we have 2 minutes.
Thank you. Very snappy. I think for the safety nature of some of the products, some of the products, especially the Nibima, there's a product from Center for Scientific Research into Plant Medicine. So issue about toxicology on that product, I'm sure when you get there, they'll be able to provide you with that information because they have a very strong toxicology department over there. So that's, I don't think should be a challenge. So that is a public knowledge. The product have been in existence for close to 20 years now. Libima is used in treating malaria. And so please check on that. You get the information.
Okay, thank you. Is that the last question?
We have one more question.
Thank you very much. So maybe this one will be for my own education. Please, one of the papers you had reviewed, you suggested they had done computational analysis, maybe using the AIs and other stuff. Is this something you came across that can be used to do some of these assessments for safety concerns? And probably could such ones help you identify which other analytes or substances are in there that are helping them, whether with the synergistic effect or whatever? Can you use AI in terms of all these things that we are seeing to help you narrow down some of the processes? Because safety processes tend to be also a bit expensive.
Now realizing that he's a student. Please, yes. Please, yes. There are other models to study the absorption, metabolism, the excretion of these compounds. We just have to get the structure, place them in there, then take time to study them. There are those models in there. The only limitation is they are computational studies. So when we try them in vitro, sometimes we don't see what we saw in the computation.
I just wanted to add that these systems do exist. So the big pharma and all that, they have big libraries. You screen all of them for those before they even go into the lab.
Thank you very much. I wish all our students were like this. I'm really very impressed with this young man. You've done extreme, you've done us very. So on that note, I'd like to thank all of you for your presentations and for the education you've provided us. Can we give them a round of applause as they sit down, take their seats? Thank you. Yeah, I know. Oh.
Okay, thank you very much. Before we call our VC to give us the closing remark, we would call Mr. Maoli Ibuagbe to give us the announcement.
Thank you. Because the Japan babies are making Professor Japan proud. I think we can give him another round of applause. This form comes with CPD points, continuous professional development from the Medical and Dental Council, the Allied Health Professionals Council, and those interested to register for it. And so from tomorrow, we would collect the names for CPD, and it goes for a fee of 50 cedis per 50 cedis, and you have to register for it. And this requires your full participation for these 3 days. Those of you participating online, we're taking the online attendance, and you have to also indicate and find a way of getting payment done for you by any of the participants. And by so doing, you will be entitled to the CPD points when this arrangement is finally through. And that's for our announcement. Tomorrow, We will begin same time here. And we urge you all to be in time, not on time. We urge you to come early so that we can begin early. Thank you.
I didn't realize I was supposed to make closing remarks today, but it's okay. Pity of having the microphone again. So I can say that together with Professor Fletcher, we made the right decision to start the FAMD program 6 years ago. You know, when you don't know the history of some, you take them for granted. We had a lot of criticisms for running ahead of ourselves, and we thought it was the right time. And we brought in, was it 32 students or 30 students, thereabouts? I'm impressed that the first can come and stand here and give an exposition on this subject matter like this. So these are my concluding remarks for the day. That it was the right thing to start the FAMD program. I'm not sure who made the comments at the back there that we should go to Center for Plant Medicine to go and check. It's neither here nor there. When you are doing these things, your information must be up to scratch. And I can assure you that if you look at some of the data that are presented from the medicine research, as we do for the regular scientific clinical trials that we do. So, but I wish that you would all return tomorrow, participation in a full day, have an evening rest. We'll meet again tomorrow morning. Thank you very much.
Thank you, VC. We'll call on Professor Margaret Japon for a short presentation, a very short one. Let's clap for her, please.
Thank you very much. The room is so empty. I hope tomorrow people will come for the afternoon session very strongly. It's been a pleasure having all of you here today. We have a small presentation to make to our keynote speaker. As we said, we called him at short notice. In fact, he used to have a multitude of troubles, but after responding to our call at such short notice, IHR decided that by the grace of God, his sins are forgiven. But he delivered such a beautiful lecture this morning, and we want him to remember UHAS wherever he is in his office, and to know that when our lights come, we'll be looking nicer than KNU ST. So Prof. Ellis, please come. So, Prof. Ellis, the University of Health and Allied Sciences honors you for delivering the keynote address at its second Research Dissemination Forum on the theme Multidisciplinary Research for Health and Development in a Global Pandemic, presented 27 July 2022.
Okay. Let's give it to him for coming all the way from Kumasi. We are so grateful. Shall we please bow down our head for a closing prayer? Father, we thank you for this day. We thank you for the successes that we've accomplished. We thank you for the learning and unlearning activities that have occurred today. As we return to our various places to have rest, we pray for sound rest. We pray for your protection. We pray for transport mercies to those who also be traveling. And at the end, we'll join hands and say, glory be to your name. Amen. Thank you very much for coming. And hopefully we'll meet tomorrow. Thank you.
All committee members, research dissemination committee members, we are meeting upstage for just a few minutes. All committee members, thank you.